Okay, let's unpack this. When you think about the absolute control center of your entire body, the organ that orchestrates everything, what comes to mind?
Uh-huh.
For most of us, it's the brain, right? But nestled deep within that skull, there's a tiny, unassuming gland, often called the master gland, that, well, in concert with the brain, orchestrates so much more than you might imagine.
It's truly remarkable how this small structure, I mean, despite its profound influence on virtually every system in the body, it sort of remains in the shadows of popular understanding. Its reach is just incredibly extensive, touching nearly every aspect of our physiology.
And that's exactly why we're taking a deep dive into the pituitary gland today. Our mission is to go beyond the basics. We're going to trace its surprising ancient origins, explore its intricate development, unravel the complex hormonal axis it controls, and understand the myriad ways things can go awry.
Right.
Our goal for you, the listener, is to gain the kind of understanding that sets well-informed apart from elite professional. You'll really master this information.
Our guide for this journey is a dense, authoritative endocrine textbook, a real treasure trove of detailed knowledge. We've meticulously extracted the most critical insights and fascinating nuances, presenting them in a way that makes this complex subject not just understandable, but genuinely captivating.
Yeah.
By the end of this deep dive, you'll possess a mastery of this information that mirrors the elite professionals in the field.
Okay, so let's begin at the very beginning with its name, which I find quite, well, amusingly misleading.
Mm-hmm.
The word pituitary actually comes from the Greek put and Latin pituita, both meaning phlegm. Can you believe that's how this incredibly vital gland got its name?
It truly is a testament to the evolving nature of scientific understanding, isn't it? This etymology, it harkens back to Galen, a prominent physician in the 2nd century. He hypothesized that the brain produced nasal phlegm, which then drained directly through this gland. It was an ingenious, if, well, entirely incorrect, early attempt to explain the connection between the brain and bodily secretions.
It perfectly illustrates how our understanding of the body isn't static. We move from these early, sometimes quirky hypotheses to increasingly refined models. Fast forward to the 17th century, we see Descartes beginning to propose a more direct role for the brain in fundamental bodily functions.
Right.
And then in the 19th century, researchers started piecing together specific groundbreaking insights. For example, Morgagni, observing the absence of adrenal glands in an anencephalic neonate.
Yeah.
He unknowingly hinted at a critical developmental link between brain structures and peripheral endocrine organs.
Absolutely. And Claude Bernard, back in 1849, he contributed significantly by demonstrating that central lesions near the 4th ventricle led to polyuria, or excessive urination. He was effectively laying foundational groundwork for what would become neuroendocrinology.
Okay.
But for our modern understanding, the truly pivotal figure is Jeffrey Harris, often hailed as the father of modern neuroendocrinology. In 1948, he reviewed the control of anterior pituitary hormones and, with remarkable foresight, predicted their hypothalamic regulation. This prediction, based on meticulous observation and logical deduction, directly paved the way for the subsequent discovery and isolation of the specific hypothalamic regulating hormones we know today.
So if we bring it to the present, our contemporary understanding is that the pituitary, working in seamless concert with the hypothalamus, acts as the grand orchestrator of the entire endocrine system. This tiny duo maintains systemic integrity, influencing everything from the thyroid and adrenal glands to the gonads, liver, cartilage, and even breast tissue. It achieves this by integrating intricate signals originating from both the central nervous system and the periphery.
That integration is absolutely key. This hypothalamo-pituitary unit isn't just important, it's completely vital for a vast array of life-sustaining functions.
Right.
Think about sexual function and fertility, linear growth and the development of our organs, lactation, our body's precise stress responses, energy regulation, appetite control, maintaining a stable body temperature, and even the intricate balance of carbohydrate and mineral metabolism.
Wow, the list just goes on.
It does. Without its precise orchestration, these systems would indeed descend into profound chaos.
Given its monumental role, it's quite fascinating how physically constrained this tiny maestro is. It's intimately nestled within a protective bony saddle called the sella turcica, which literally means Turkish saddle. and it's further covered by a tough protective dural membrane known as the diaphragma sella.
Yes, and its physical connection to the hypothalamus is equally crucial, the pituitary stalk. This stalk is much more than just an anatomical link. It's a vital functional bridge connecting the pituitary to the median eminence of the hypothalamus. Preserving this entire hypothalamo-pituitary unit is paramount because it's through this direct, uninterrupted connection that the pituitary receives the precise signals necessary to control all those critical bodily functions we just listed. Any disruption here can have widespread consequences.
And structurally, it's not just a single uniform entity. It's actually composed of three main parts: the predominant anterior lobe, the posterior lobe, and a smaller, less prominent sort of vestigial intermediate lobe.
In a typical adult, this gland is surprisingly small, weighing only around 600 milligrams. To give you a sense of its proportions, it measures roughly 13 millimeters across, 6 to 9 millimeters vertically, and about 9 millimeters from front to back.
Tiny.
Very. However, its size isn't entirely static. It can vary noticeably, particularly in women who have had multiple pregnancies, and can even increase up to 1 gram during pregnancy due to, well, hormonal changes.
And within this compact structure, the anterior lobe houses 5 distinct types of hormone-secreting cells, each with a specialized role. First, we have the corticotropes, which are responsible for producing ACTH, derived from larger POMC peptides. Then there are somatotropes, the primary secretors of growth hormone, or GH. Thyrotropes produce TSH, which is a common alpha subunit shared with other hormones, but its own specific beta subunit. Gonadotropes, producing FSH and LH, also share that common alpha subunit, but possess unique beta subunits that give them their specific functions.
Exactly, conferring specificity.
And finally, lactotropes, which are dedicated to producing prolactin, or PRL.
What's critical for understanding its precision is that each of these 5 cell types operates under its own highly specific and intricate signal controls. And beyond these hormone-producing powerhouses, the pituitary also contains essential support cells, like pituocytes or folliculostellate cells, which play roles in maintaining the gland's overall structure and function.
Now let's talk about something truly unique and vital to the pituitary's function: its blood supply. It receives an incredibly abundant blood supply from both the superior and inferior hypophyseal arteries.
Okay, here's where it gets really interesting, and it illustrates a masterclass in biological engineering. The hypothalamic portal circulation is the key.
The portal system.
Exactly. This specialized system is formed by long and short hypophyseal portal vessels that originate from the median eminence and the pituitary stalk, respectively. This portal system is the predominant blood supply to the anterior pituitary, and its ingenious design allows it to deliver hypothalamic hormones directly to the hormone-producing cells of the adenohypophysis without significant systemic dilution.
Okay. Undiluted signals.
Precisely. This direct, concentrated delivery mechanism is what enables the incredibly sensitive and precise regulation by timed hypothalamic hormone secretion. It's like a dedicated express lane for signals.
So it's not just about blood flow, but about direct, undiluted signaling. That's a profound design. And you mentioned gomatoli. That sounds like a fascinating local control mechanism.
Absolutely. The gomatoli are a contractile internal capillary plexus, basically specialized networks derived from branches of the superior hypophyseal arteries within the stalk itself. They're believed to be involved in the local regulation of how hypothalamic hormones are transported. And there's another layer of sophistication: retrograde blood flow. This means blood can flow backwards or retrogradely towards the median eminence.
Backwards.
Yeah. This bidirectional flow facilitates incredibly important functional interactions between the hypothalamus and the pituitary, allowing for dynamic feedback and communication.
So it's not just a one-way street of signals. It's a sophisticated, active exchange that's truly advanced. Let's shift our focus to how this complex gland develops, starting from its very embryonic origins. The anterior pituitary originates from something called Rathke's pouch. What exactly is that?
Rathke's pouch is a primitive ectodermal invagination, essentially an outpocketing of tissue, that appears anterior to the roof of the oral cavity during early embryonic development. This pouch initially maintains a connection to the stalk and the hypothalamic infundibulum, but eventually it separates from the oral cavity and nasopharynx, becoming its own distinct structure.
Okay.
It's fascinating that sometimes remnants of this pituitary tissue can persist in the nasopharyngeal midline.
Really?
Yeah, and in rare cases, these remnants can even give rise to ectopic, hormone-secreting tumors later in life. Meanwhile, the neurohypophysis, which is the posterior pituitary, arises from neural ectoderm, specifically tissue associated with the development of the third ventricle of the brain.
And this entire process unfolds on a remarkably precise and rapid timeline. The human fetal Rathke's pouch is already clearly evident at just 3 weeks of gestation. 3 weeks? I know. By 7 weeks, the anterior pituitary vasculature begins to develop, and by a mere 20 weeks, the entire hypophyseal portal system, that critical direct delivery network we just discussed, is fully established.
What's particularly noteworthy is how early major cellular differentiation occurs within the anterior pituitary, largely during the first 12 weeks of gestation. By this point, all the major secretory cell compartments, the different cell types that will eventually produce hormones, are structurally and functionally intact, with the exception of lactotrophs, which undergo their final maturation later.
So how do these different specialized cell types emerge from what starts as a relatively undifferentiated pouch?
It's a beautifully orchestrated process. Pluripotent pituitary stem cells, cells that have the potential to become many different types of cells, differentiate into distinct acidophilic and basophilic cell lineages.
Okay, 2 main branches.
Right. The acidophilic lineage gives rise to mammosomatotroph, somatotroph, and lactotroph cells, while the basophilic lineage produces corticotroph, thyrotroph, and gonadotroph cells. These distinct cell types appear at clearly demarcated developmental stages. For instance, corticotroph cells are morphologically identifiable at an incredibly early 6 weeks of gestation.
6 weeks.
And immunoreactive ACTH, the hormone they produce, is detectable by 7 weeks. Somatotroph cells, responsible for growth hormone, are evident by 8 weeks, already containing abundant immunoreactive cytoplasmic GH.
That's an astonishing level of specificity so early on.
Yeah.
What are the key signals that guide this incredibly precise formation and differentiation?
It's a complex symphony of signaling. Critical neuroectodermal signals, such as bone morphogenetic protein 4, BMP4, fibroblast growth factor, FGF8, FGF10, WNT5, and WNT4, are absolutely essential for the initial pituitary morphogenesis, its overall shaping and structure.
Right, the basic blueprint.
Exactly. Following this, the subsequent ventral developmental patterning and the precise expression of transcription factors are meticulously directed by the spatial and graded expression of factors like BMP2 and sonic hedgehog SHH protein. These are crucial for establishing the early patterns of cell proliferation that lay the groundwork for the mature gland.
Now, let's turn to pituitary stem cells, because this concept truly hints at the gland's remarkable regenerative and adaptive power throughout life. The adult pituitary gland actually exhibits quite plastic and regenerative trophic properties, allowing it to maintain its homeostatic functions.
That's a key point. A prime example of this inherent plasticity is the significant expansion of pituitary lactotrophs during pregnancy as the body prepares for lactation.
Makes sense.
Another instance is the hyperplasia, an increase in the number of cells of pituitary trophic hormone cells that occurs after a target organ, like the thyroid or adrenal gland, has been ablated. These intrinsic capabilities are absolutely fundamental to the pituitary's adaptability and its ability to respond to changing physiological demands.
So these stem cells are actively generating new cells during early postnatal development, which makes sense for growth. But then they become largely quiescent in adulthood.
That's generally correct. However, researchers have successfully identified and characterized pituitary cells that possess the true hallmarks of a stem cell phenotype.
Ah, so they are there.
They are there. These include an undifferentiated gene profile, the capacity for clonality, the ability to form colonies in culture, and importantly, the expression of key stem cell markers like SOX2, SOX9, and OCT4. This provides concrete evidence of their existence and potential.
What's fascinating here, and truly pushes the boundaries of our understanding, is that cell lineage tracing studies have directly demonstrated that SOX2 and SOX9 expressing progenitors can not only self-renew but also give rise to various pituitary endocrine cells in vivo. This provides compelling evidence for their role as bona fide tissue stem cells. And it's not just theoretical. There have been significant advances in recapitulating pituitary differentiation in vitro.
Indeed. Using three-dimensional 3D cultures of embryonic stem cells, scientists have successfully stimulated them to differentiate into structured, Rathke's pouch-like 3D formations.
Wow.
And from these structures, they've been able to produce various functional endocrine cells, including corticotrophs and somatotrophs. This is a monumental step towards understanding development and potential therapies.
This sounds like it could dramatically reshape future medical interventions. What are the broader implications of these advances?
These breakthroughs open significant and exciting avenues for novel regenerative therapies for pituitary diseases, especially for conditions like hypopituitarism, where there's a deficiency in one or more pituitary hormones.
Right, replacing lost function.
Imagine the potential for restoring lost function. They also profoundly enhance our understanding of the potential role of pluripotent pituitary stem or progenitor cells in pituitary tumorigenesis, providing crucial new insights into how pituitary tumors might form and, importantly, how we might target them more effectively.
So, with all this intricate structure and the various specialized cell types, how exactly is the secretion of these vital hormones controlled? Our sources describe a sophisticated, multi-tiered system.
That's an excellent way to frame it. The first tier is hypothalamic control. This involves specific adrenocorticotropic hormones, think of them as messenger molecules, which are secreted from the hypothalamus directly into that specialized hypothalamic portal system we discussed earlier.
Got it.
These hormones then immediately bind to selective and specific cell surface receptors on the anterior pituitary cells, eliciting either positive signals to stimulate hormone gene transcription and secretion, or negative signals to inhibit them.
And then there's a crucial local control system operating right within the pituitary gland itself, correct?
Precisely. That's intrapituitary control, the second tier.
Right.
Here, paracrine factors, signals that act on neighboring cells, and autocrine factors, signals that act on the same cell that produced them, including various growth factors and cytokines, work locally to regulate the development and function of adjacent cells.
Okay, local chatter.
Exactly. This allows for incredibly fine-tuned coordination and adaptability within the gland, ensuring appropriate responses.
And the third tier sounds like the classic feedback loop we often hear about in endocrine systems.
It is, and it's essential for maintaining balance. This is peripheral hormone feedback. It predominantly involves negative feedback regulation, where the trophic hormones secreted by the pituitary are inhibited by their respective target hormones produced by the peripheral glands.
Like thyroid hormone shutting down TSH.
Exactly. If your thyroid gland produces too much thyroid hormone, that hormone will feed back to the pituitary to inhibit the release of TSH, thus slowing down thyroid activity. This ensures the body doesn't overproduce hormones.
The ultimate result of all these intricate tiers of intracellular signals is the controlled pulsatile secretion of the 6 primary pituitary trophic hormones. ACTH, GH, PRL, TSH, FSH, and LH.
And this sophisticated temporal and quantitative control isn't just a biological curiosity. It's absolutely critical for the physiological integration of all our peripheral hormonal systems.
Right.
A perfect clinical example is the female menstrual cycle, which relies entirely on a complex, precisely regulated pattern of hormonal pulses to function correctly and enable reproduction.
Moving now into our deep dive into specific hormone axes, let's start with the prolactin, or PRL axis. While it's primarily known for milk production, its broader physiology is quite unique.
Indeed. Prolactin is mainly produced by pituitary lactotrophs, which constitute a significant portion, about 15% to 25% of the anterior pituitary cells. What gives PRL a unique characteristic, setting it apart from virtually all other pituitary hormones, is that it is uniquely under tonic inhibitory hypothalamic control by dopamine.
Inhibitory control.
Okay.
So it's usually suppressed.
Exactly. Unlike most pituitary hormones that need a releasing signal, PRL release is normally suppressed by dopamine from the hypothalamus, and it's released when this suppression is lifted.
I found it surprising that it was actually quite challenging to identify human PRL until as late as 1970. Why was that such a struggle for researchers?
Well, it was elusive primarily because human growth hormone, or GH, actually possesses significant lactogenic activity, meaning it could stimulate milk production.
Ah, a confounding factor.
Right. So it was active in the early bioassays used to isolate and measure PRL. To make matters more complicated, GH is present in human pituitary glands in much higher concentrations, on the order of 5 to 10 milligrams, compared to PRL, which is only present at around 100 micrograms.
Huge difference.
Yeah. This made the task of isolating and identifying PRL specifically, distinct from GH, quite a formidable challenge for early endocrinologists.
So it seems most PRL-expressing cells have a close developmental tie to GH, often arising from GH-producing cells. And there's a specific protein, ZBTB20, that's important for lactotroph lineage specification.
That's correct. Furthermore, lactotroph cells themselves display a degree of heterogeneity, meaning they're not all identical. We even see occasional mammosomotrophs, which are cells that co-secrete both PRL and GH, sometimes storing both hormones within the same secretory granules.
Interesting overlap.
It highlights the intricate and sometimes overlapping developmental pathways within the pituitary.
Now, let's explore PRL's structure. It's a 23 kilodalton protein composed of 199 amino acids, and it has two independent promoter regions that meticulously regulate its gene transcription. A proximal promoter that drives pituitary-specific expression, and a distal promoter that allows for its expression in extrapituitary tissues.
Okay, here's where it gets really interesting, showing how a single hormone can have multiple biological identities. While the full monomeric PRL is the main form, it can actually be proteolytically cleaved into smaller, distinct forms, specifically 8 and 16 kilodalton fragments.
Okay.
The 16 kilodalton variant is particularly significant because it's also known as vasoinhibin, and it possesses potent anti-angiogenic properties.
Anti-angiogenic, so it inhibits the formation of new blood vessels, which sounds counterintuitive for a hormone involved in development.
Yeah.
How does that tie into its broader implications, especially clinically?
Precisely. Its anti-angiogenic action has profound clinical implications. Vasoinhibin has been definitively implicated in peripartum cardiomyopathy.
Oh, the heart condition in pregnancy.
Exactly. A serious and life-threatening heart condition that can occur during late pregnancy or postpartum. The mechanism involves vasoinhibin acting on capillary endothelial cells, stimulating them to produce a specific microRNA called miR-146A. This miR-146A then acts in a paracrine manner, meaning it signals to neighboring cells on cardiomyocytes, inhibiting their metabolism by blocking the activity of ERB4, a crucial tyrosine kinase receptor.
Wow.
This entire cascade ultimately impairs normal cardiac function.
So there's a direct molecular link between this specific PRL fragment and heart dysfunction, which is quite surprising. And you mentioned a treatment that targets this pathway.
Yes. For peripartum cardiomyopathy, treatment with the dopamine agonist bromocriptine has been shown to significantly improve cardiac function in these patients.
Bromocriptine. Right.
This improvement occurs in parallel with a measurable reduction in miR-146A levels, directly supporting the therapeutic potential of targeting this specific pathway. It's a clear example of how understanding molecular details can lead to effective clinical interventions.
Moving on, the PRL receptor itself is a key player, belonging to the cytokine receptor superfamily, and it's found on chromosome 5p13. How does its activation pathway work at the cellular level?
Its activation involves receptor dimerization. A single PRL molecule binds to and bridges two receptor components, causing them to come together.
Okay, they pair up.
Right. This dimerization then triggers the phosphorylation of intracellular JAK-STAT molecules, a critical signaling cascade. Of these, STAT5 is particularly important, playing a crucial role in normal mammary gland development and the process of lactogenesis.
And it's not just for milk production. The PRL receptor is ubiquitously expressed across an incredibly vast array of tissues. You've mentioned breast, pituitary, liver, kidneys, prostates, even the brain and immune cells.
This widespread expression underscores its diverse and far-reaching functions beyond its classic role in reproduction. Clinically, this ubiquitous presence is significant. For instance, mice with inactivated PRL receptors are infertile, demonstrating its essential reproductive role. In humans, a gain-of-function mutation in the PRL receptor has been identified in a subset of patients with multiple breast fibroadenomas. And remarkably, PRL receptor antagonists have even been developed and are being explored for their therapeutic potential in targeting the receptor in conditions like resistant prolactinomas, breast tumors, and prostate tumors.
So beyond its well-known reproductive roles, what other proposed functions does PRL have, considering its widespread receptor distribution?
Well, it's been suggested to play roles in a number of other critical systems. For instance, in immune function, it appears to offer protective effects against inflammation-induced chondrocyte apoptosis in rheumatoid arthritis.
Interesting.
In rodents, it's clearly involved in maternal behavior, though its precise role in human maternal behavior needs further study. Other proposed roles include neurogenesis, influencing the formation of new neurons, metabolism and glucose homeostasis, appetite regulation, and maintaining bone and calcium homeostasis.
So quite a lot, potentially.
Yes. Furthermore, the impact of extrapituitary PRL, which is produced locally in various tissues, on processes like cancer development and autoimmune diseases, remains an active and crucial area of ongoing investigation.
When it comes to measuring PRL in a clinical setting, there are some unique challenges. It's typically measured by automated immunoassays calibrated against a WHO standard, and normal values are generally higher in women than in men.
What's fascinating here, and a critical diagnostic pitfall for clinicians, is what's known as the hook effect.
Hook effect, okay.
In two-site immunoassays, if the PRL concentration is extremely high, far beyond the normal range, it can actually saturate both the capture and signal antibodies in the assay. This prevents the formation of the sandwich complex that the assay relies on, leading to a falsely low or only moderately elevated reading.
Falsely low, that's dangerous.
It is. This means a patient with a very large, actively PRL-secreting macroadenoma, which would normally have sky-high PRL levels, could be misdiagnosed as having a clinically non-functioning adenoma, which is a very different clinical picture.
Completely different management.
Completely. To avoid this, it's absolutely crucial that serum samples from patients with suspected macroadenomas and very high PRL levels are subjected to at least a 1.100 dilution before being reassayed.
That's a profound point for accurate diagnosis. And there's also something called macroprolactin that can confound results.
Yes. Macroprolactin is a physiologically inactive form of prolactin. It occurs when monomeric prolactin molecules bind to immunoglobulin G, or IgG. This macroprolactin, while inactive, is still detected by standard immunoassays.
So the assay sees it, but the body doesn't use it.
Precisely, leading to falsely elevated prolactin levels and a misdiagnosis of hyperprolactinemia, when in fact the patient doesn't have excess biologically active hormone. To prevent this, laboratories can routinely pretreat serum samples with polyethylene glycol, which precipitates the macroprolactin, allowing the immunoassay to be performed on the supernatant containing only the active prolactin.
Simple but crucial step.
A simple but vital step for accurate diagnosis.
So given these measurement intricacies, what are the primary causes of hyperprolactinemia?
Hyperprolactinemia can broadly be categorized into physiologic, pathologic, or drug-induced. Physiologic causes are natural processes. Pregnancy, suckling, stress, both physical and psychological, sleep, coitus, and exercise.
Okay, the normal stuff.
Right. Pathologic causes primarily involve prolactinomas, which are benign pituitary tumors that secrete excess PRL and can present with any level of PRL elevation. Other pituitary or cellular tumors, even if not directly secreting PRL, can still cause hyperprolactinemia by inhibiting dopamine release due to pressure on the pituitary stalk or disruption of the vascular connections.
Stalk effect.
Exactly, the stalk effect. For instance, a serum PRL level greater than 2,000 million units per liter is almost never attributable to stalk dysfunction alone, strongly suggesting a prolactinoma.
Are there other traumatic or inflammatory causes?
Yes. Severe head trauma can induce hyperprolactinemia, often alongside other anterior pituitary hormone deficiencies. Cranial and hypothalamic irradiation also frequently leads to moderate hyperprolactinemia in about 50% of patients. Interestingly, hyperprolactinemia has also been reported in cases with inactivating prolactin receptor mutations, suggesting a central negative feedback mechanism at play in humans. And lymphocytic hypophysitis, an autoimmune inflammatory condition of the pituitary, can also be associated with elevated PRL levels.
And drug-induced hyperprolactinemia is quite common in clinical practice, isn't it?
It is indeed, and it's a critical consideration in differential diagnosis. A wide array of medications can cause it. Neuroleptic drugs, for example, elevate PRL due to their dopamine receptor antagonist properties, as do many atypical antipsychotics. Drugs that inhibit dopamine synthesis, like alpha-methyl-dopa or catecholamine depleters, such as reserpine, also increase PRL. Other culprits include certain cholinergic agonists, some antihypertensives like labetalol and verapamil, H2 antihistamines, estrogens like those in oral contraceptives or even during withdrawal, some anticonvulsants, phenytoin, opiates, and various antidepressants, TCAs, SSRIs.
Wow, it's a huge list.
It is. Even immune checkpoint inhibitors, increasingly used in cancer immunotherapy, can, in rare instances, cause hyperprolactinemia, although more commonly they lead to prolactin deficiency.
That's a remarkably long list to keep in mind. So, how is drug-induced hyperprolactinemia typically managed?
Well, if the patient's clinical situation and underlying condition permit, a temporary withdrawal of the suspected drug can be considered to see if PRL levels normalize.
Stop the drug, see what happens.
Basically. If withdrawal isn't feasible, or if the levels remain elevated, a pituitary MRI should be performed to rule out a tumor. If neuroleptics are the causative agent, switching to an alternative like olanzapine might be an option, as it generally has minimal effects on PRL levels, offering a therapeutic solution without compromising mental health treatment.
What about prolactin deficiency itself? What causes it, and what are its manifestations?
Congenital PRL deficiency can arise from mutations in transcription factors crucial for lactotroph development, such as POU1F1, PROP1, LHX3, and HESX1. In these genetic cases, PRL deficiency almost invariably co-occurs with deficiencies in other anterior pituitary hormones.
Right, part of a bigger picture.
Usually. Notably, PRL deficiency has also been linked to central hypothyroidism in patients with IGS-F1 mutations. Acquired causes include autoimmune lymphocytic hypophysitis and hypophysitis induced by immune checkpoint inhibitors. Historically, Sheehan syndrome, which is pituitary infarction following postpartum hemorrhage, was a common cause, but its incidence has significantly decreased due to improvements in obstetric care.
And what's the clinical manifestation? What does a person with PRL deficiency actually experience?
The only known clinical manifestation directly attributable to PRL deficiency is the inability to lactate after delivery.
Really that?
That's the key specific one. This is a very specific and crucial point. Isolated PRL deficiency is, in fact, exceedingly rare. The vast majority of patients who acquire PRL deficiency will present with concurrent deficiencies in other pituitary hormones, making it part of a broader hypopituitary syndrome.
Okay.
Currently, there is no commercially available PRL preparation for therapeutic use, though recombinant human PRL has shown promise in research settings for increasing milk volume in women experiencing lactation insufficiency.
Let's transition now to the growth hormone, or GH axis. This system is absolutely crucial for growth, metabolism, and surprisingly, even has implications for longevity.
GH is primarily produced by somatotroph cells, which are the most abundant cell type in the anterior pituitary, comprising 35% to 45% of its cells. They are predominantly located in the lateral wings of the anterior pituitary gland and are distinctly ovoid in shape with large secretory granules, which are essentially storage vesicles for GH.
And the human GH genome is quite an intricate piece of genetic architecture, isn't it?
It truly is. The human GH genome locus spans approximately 66 kilobases and contains a tightly clustered group of 5 highly conserved genes located on chromosome 17q2224.
5 genes.
Yeah. These genes encode HGHN, which is the form expressed in pituitary somatotrophs, as well as other forms like HGHV and human chorionic somatomammotropin HCS genes, which are predominantly expressed in the placenta during pregnancy.
What are the main circulating forms of GH once it's produced?
The HGHN gene primarily codes for a 22 kilodalton protein consisting of 191 amino acids, which accounts for approximately 75% of the total pituitary GH secretion.
A main one.
Right. There's also a significant 20 kilodalton form, which results from alternative splicing of the primary RNA transcript and makes up about 10% of circulating GH. Beyond these main forms, the pituitary also produces various other variants through post-translational modifications, such as deamidated, acylated, and glycosylated forms, each potentially with slightly different biological activities.
You mentioned the PO1F1 transcription factor is involved in GH expression, and there's a crucial locus control region located far upstream of the HGHN promoter. What's its significance?
This locus control region, positioned 14.5 kilobases upstream of the HGHN gene, is incredibly important for precise control. It's responsible for conferring and restricting the expression of GH specifically to somatotrophs and mammosemotrophs, the specific cell populations that also express PIT1 during development.
Targeting.
Exactly. Critically, it also plays a major role in sustaining the high level of HGH gene expression required for robust GH production in these specialized cells. Without it, GH expression would be significantly impaired or misdirected.
What about extrapituitary GH?
First,
Is GH expressed outside the pituitary in other tissues, and if so, what's its role there?
absolutely. GH is expressed in a variety of extrapituitary tissues, including key areas like the brain, immune cells, and various parts of the reproductive tract, such as the breast, ovary, testes, and prostate. It's also found in the gastrointestinal system, including the liver, pancreas, and gut, as well as the lungs. In these diverse tissues, GH appears to function primarily in an autocrine and paracrine manner.
Local action.
Exactly, meaning it acts locally on the cells that produce it or on neighboring cells. Its roles in these contexts are generally related to localized developmental and proliferative functions.
This raises an important question. If it's involved in proliferation, does that connect to its role or potential role in cancer?
It does. The expression of extrapituitary GH is indeed strongly implicated in the neoplastic transformation, the process leading to cancer of various tissues, particularly breast, prostate, and colonic neoplasms. Research has clearly demonstrated that nuclear targeting of the GH receptor, meaning the receptor is active inside the cell's nucleus, can lead to a significant dysregulation of cell proliferation, contributing directly to tumorigenesis. This highlights a crucial dual nature of GH's influence.
So GH secretion isn't a steady, constant release throughout the day. It's episodic and follows a distinct diurnal rhythm.
That's a fundamental characteristic of GH physiology. Approximately 2/3 of the total daily GH secretion occurs during the nighttime, specifically triggered by the onset of slow-wave sleep.
Deep sleep.
Right. Conversely, GH levels are at their lowest point, or nadir, during the daytime, and can even be undetectable during certain periods, particularly in elderly or obese individuals. This pulsatile nocturnal pattern is essential for its biological effects.
And how do GH levels naturally change throughout a person's life, from infancy to old age?
GH concentration is remarkably high in fetal circulation, peaking around 150 micrograms per liter during mid-gestation. After birth, neonatal levels drop to about 30 micrograms per liter, likely due to negative feedback from rising IGF-1 levels.
Okay.
It then falls to a stable level during childhood before undergoing a significant increase, rising 2 to 3-fold at the onset and peak of puberty.
The growth spurt.
Exactly. However, from the third decade of life onwards, GH secretion progressively declines exponentially, decreasing to about 50% of peak levels by changes in pulse amplitude rather than frequency. This age-related decline is a natural physiological process.
What about external influences on GH secretion, such as stress or physical activity?
Exercise and stress, including physical trauma or severe conditions like sepsis, generally lead to an increase in GH levels. Conversely, emotional deprivation and endogenous depression can significantly suppress GH secretion. It's also important to note that IGF-1 levels, a key mediator of GH action, closely reflect GH output throughout life, making age-stratified IGF-1 measurements a valuable and reliable serum marker for assessing GH status in both sexes.
Nutrition clearly plays a major and immediate role in regulating GH. How does it influence secretion?
It absolutely does, and the interplay is dynamic. For example, insulin itself has inhibitory actions on GH secretion. Malnutrition typically leads to an increase in GH secretion, whereas obesity tends to decrease it.
Makes sense.
These nutritional effects can be quite acute. Fasting, even within 12 hours, significantly amplifies GH secretion, while glucose ingestion predictably suppresses it. Specific amino acids, such as arginine and leucine, are known to stimulate GH release. Conversely, free fatty acids can blunt this release.
Okay.
Leptin, a hormone secreted by adipose tissue, acts as a critical metabolic signal, stimulating GH secretion by interacting with both somatostatin and GHRH pathways, as well as the neuropeptide Y system, linking our energy stores directly to growth signals.
If we connect this to the bigger picture, it sounds like there's a complex, dynamic, almost rhythmic interaction between hypothalamic somatostatin, or SRF, and GHRH that drives this crucial pulsatile GH release.
That's precisely it, and it's a beautiful example of neuroendocrine control. SRIF and GHRH are secreted in independent, often out-of-phase waves, and their coordinated action is what generates those characteristic pulsatile GH releases.
Like a push and pull.
Exactly. For instance, SRIF administration or its increased presence generates the troughs in GH secretion, effectively turning off the PAP, while GHRH generates the surges, opening it. In humans, administering GHRH antagonists inhibits GH pulses, unequivocally demonstrating GHRH's essential role in this pulsatile secretion pattern.
Clear proof.
Right. The finely tuned, coordinated secretion and action of both SRIF and GHRH are what ultimately result in the periodic pulsatile release of GH from the pituitary.
So what happens with chronic GHRH stimulation? Does the pituitary just keep releasing more and more GH?
Not at all. Chronic GHRH stimulation, whether delivered through continuous infusion or repeated bolus injections, eventually leads to a desensitization of GH release.
It gets tired out.
Sort of. This likely occurs by depleting the readily releasable GHRH-sensitive pool of GH within the somatrophs, and potentially by decreasing the number of GHRH binding sites on these cells. Furthermore, GH itself participates in this intricate feedback system. It directly stimulates hypothalamic SRIF release. Both GHRH and SRIF also autoregulate their own secretion. And finally, IGF-1, the primary mediator of GH action, also contributes to this negative feedback by stimulating hypothalamic SRIF release and inhibiting GH gene transcription and secretion at the pituitary level. It's a very tightly regulated system.
What about other hormones and their impact on the GH axis? Do glucocorticoids, for example, influence it?
They certainly do. Glucocorticoids like cortisol acutely stimulate GH secretion, but paradoxically, chronic glucocorticoid treatment tends to inhibit it.
Huh, interesting paradox.
It is. Thyroid hormones are absolutely required for the proper function of the entire GH system. Without adequate thyroid hormones, GH action is impaired. Gonadal steroids, too, play a significant role. Testosterone stimulates GH secretion, an effect largely mediated centrally and dependent on its prior aromatization into estrogen.
Okay.
Estrogen, particularly when administered orally, potently stimulates GH secretion. This occurs due to a first-pass hepatic effect, where oral estrogen reduces the liver's production of IGF-1. This reduction in IGF-1 then lessens the negative feedback on the pituitary, thereby enhancing GH secretion.
The liver effect.
Right. Thus, estrogens have a dual action, acting both centrally in a paracrine manner to stimulate GH release and peripherally in an endocrine manner by enhancing GH secretion via reduced IGF-1 feedback.
Let's discuss GH action at the cellular level and those intriguing GH-binding proteins. How does GH actually transmit its signal?
At the cellular level, GH exerts its effects by binding to the growth hormone receptor, or GHR, located on the cell surface. This binding event triggers the GHR to dimerize, meaning two receptor molecules come together.
All right, the pairing again.
This dimerization then activates an associated protein kinase called JA2, which in turn phosphorylates STAT-T5, a signal transducer and activator of transcription. Specifically, STAT5 is crucial for mammary development and lactogenesis, while STAT5B is vitally important for linear growth and for dictating sex-specific liver enzyme expression.
And the GH-binding proteins, or GHBPs, what role do they play in the circulation?
There are two forms of GHBPs in circulation, a smaller 20 kilodalton low-affinity GHBP and a larger 60 kilodalton high-affinity GHBP. The high-affinity GHBP is particularly interesting because it corresponds directly to the extracellular domain of the GHR itself.
Oh, it's like a shed piece of the receptor.
Exactly. This circulating protein binds approximately half of the circulating 22 kilodalton GH and is generated by proteolytic cleavage, for example, by an enzyme called tumor necrosis, factor alpha converting enzyme.
So what exactly is their function? Why are these proteins so important to GH physiology?
Well, they serve several critical functions that fine-tune GH's action. First, GHBPs help to dampen the acute oscillations in serum GH levels that naturally occur with pulsatile pituitary GH secretion, effectively buffering rapid changes.
Smoothing out the peaks and valleys.
Right. Second, by binding to GH, they prolong its half-life in circulation by reducing its renal clearance, allowing it to act for longer. Furthermore, the high-affinity binding protein directly competes with GH for binding to surface GHRs on target cells, thereby altering GH's pharmacokinetics and its distribution throughout the body, influencing where and how strongly GH can exert its effects.
Are there levels affected by GH status? For example, are they high in GHD or low in acromegaly?
Interestingly, GHBP concentrations are generally unaffected by overall GH status, whether in states of GH deficiency or GH excess, like acromegaly. However, their levels are low in specific conditions, such as Laurent dwarfism, which is a GH receptor deficiency, and in some cases of idiopathic short stature, as well as in African pygmies. Conversely, GHBP levels increase in conditions like obesity, pregnancy, during refeeding after a period of fasting, and with oral estrogen administration.
Right, that estrogen effect again.
Exactly. They are reduced in malnutrition, cirrhosis, hypothyroidism, and in the presence of glucocorticoids and androgens.
Beyond its well-known role in growth, GH is also a major metabolic hormone in adults. How does it influence our metabolism?
It's profoundly significant for adult metabolism. GH plays a crucial role in regulating energy and substrate metabolism and in optimizing body composition and physical function. It interacts very closely with insulin and meticulously controlling fat, glucose, and protein metabolism during both fasted and fed states.
Okay.
GH actively promotes fat utilization by stimulating lipolysis, which is the breakdown of fats, and fatty acid oxidation, particularly during fasting. This process helps to partition fuel utilization preferentially toward fat, thereby sparing precious protein.
Protein sparing. Important.
Very. Furthermore, it plays a key role in regulating lipoprotein metabolism by enhancing hepatic LDL receptor expression in the liver, which contributes to improving the atherogenic profile often seen in GHD patients, reducing risks associated with high cholesterol.
Diagnosing growth hormone deficiency, or GHD, can be quite tricky, partly due to challenges with the assays used to measure GH itself.
That's a critical point. There can be up to a threefold difference in GH measurement results between different assay methods.
Threefold?
Yeah. This variability primarily stems from the heterogeneity in assay components, the calibrator materials used, and the international reference preparations. For example, modern two-site monoclonal assays are specifically designed to detect only the 22 kilodalton form of GH and often return lower absolute values compared to older polyclonal radioimmunoassays, which detected a broader range of circulating GH forms.
Right.
This assay inhomogeneity creates a significant challenge for establishing and consistently applying diagnostic cutoffs across different laboratories.
And what about IGF-1 assays? Do they face similar issues?
Similar challenges arise with IGF-1 measurements. A significant historical hurdle involved interference from IGF-binding proteins, which bind over 95% of circulating IGF-1.
Oh, wow.
This previously necessitated dissociating IGF-1 from its binding proteins before immunologic detection, though newer two-site assays have largely overcome this. Despite these assay considerations, IGF-1 measurements are particularly valuable for managing GH-related disorders because a true picture of GH status can often only be estimated through repeated measurements over time. It's also vital to use age and gender-stratified reference ranges for IGF-1, as its levels naturally change significantly across the lifespan.
What are the typical clinical presentations of GHD in adults? What symptoms might someone experience?
Well, the symptoms of GHD in adults are often quite nonspecific, making diagnosis challenging. Patients commonly report persistent fatigue, a pervasive lack of energy, feelings of social isolation, low mood, difficulty concentrating, and a noticeable reduction in physical function, all of which contribute to a significantly diminished quality of life.
Sounds like a lot of things, honestly.
It does. The physical signs are also nonspecific and can include general and central adiposity, reduced lean tissue mass, decreased bone mineral density, and unfavorable biochemical changes such as hyperlipidemia and glucose intolerance. Some patients may also show evidence of macrovascular disease and impaired cardiac function. It's an interesting distinction that cardiovascular risks appear less pronounced in adults who had childhood-onset GHD compared to those who acquired the deficiency in adulthood.
Okay, let's unpack this. The source makes an intriguing, almost counterintuitive contrast between isolated GHD and GHD that's part of multiple pituitary hormone deficits, particularly concerning longevity and health.
This is profound insight that challenges conventional thinking. Patients who have a selective absence of GH action, such as those with inactivating mutations in the GH receptor, a condition known as Laron syndrome, actually exhibit enhanced insulin sensitivity, a lower prevalence of diabetes, show no evidence of premature atherosclerosis, and remarkably, have a normal life expectancy.
Normal life expectancy without GH action.
Correct. This stands in stark contrast to the increased mortality rate consistently observed in hypopituitary adults who have GHD as a component of multiple pituitary hormone deficits. This crucial distinction strongly suggests that the increased mortality in these hypopituitary adults might largely stem from suboptimal replacement regimens for their other coexisting hormone deficiencies or from other comorbid conditions rather than being solely due to the GH deficiency itself. It reframes our understanding of GHD's isolated impact.
So how is GHD actually evaluated in a clinical setting? How do we confirm a suspected diagnosis?
The diagnosis of GHD is made biochemically, but it's always crucial to interpret these results within an appropriate clinical context. This includes factors such as a patient's history of hypothalamic pituitary dysfunction, prior cranial radiation, a known childhood onset GHD, or a history of traumatic brain injury.
Need the whole picture.
Absolutely. Since the features of adult GHD are often nonspecific and can easily mimic the changes associated with normal aging, clinical suspicion must be rigorously confirmed by accurate biochemical diagnosis to ensure proper identification and, importantly, appropriate treatment.
And what remains the gold standard for provocative testing to definitively diagnose GHD?
The insulin tolerance test, or ITT, remains the gold standard for evaluating the integrity of the GH axis. In normal subjects, insulin-induced hypoglycemia triggers a robust response, with peak GH concentrations typically exceeding 5 micrograms per liter. Severe GHD is biochemically defined by a peak GH response of less than 3 micrograms per liter.
Okay, clear cutoffs.
Right. However, it's important to note that the ITT is contraindicated in patients with ischemic heart disease or seizure disorders due to the risk of inducing severe hypoglycemia. On the other hand, it offers the added advantage of simultaneously stimulating ACTH secretion, allowing for evaluation of the adrenal axis.
What about alternative provocative tests if the ITT is contraindicated or impractical?
Several other tests are validated diagnostic alternatives, including glucagon, GHRH, and ghrelin mimetics, either alone or in combination. Glucagon, in particular, is gaining attention as a simpler and safer alternative when the ITT is undesirable.
Glucagon, okay.
A crucial point for interpretation is that diagnostic thresholds for all these tests are typically reduced in obese individuals. It's also important to recognize that patients with 3 or 4 existing pituitary axis deficiencies involving the thyroid, adrenal, gonadal, and/or vasopressin axes are almost invariably GH deficient.
If they have multiple problems already.
Exactly. In these cases, there's a 95% to 100% chance of GHD if their IGF-1 level is subnormal, meaning these patients usually don't require further stimulation testing.
And can these alternative tests always pinpoint the underlying cause of GHD, or are there limitations?
There are indeed limitations. Tests that directly stimulate GH release from the pituitary, such as GHRH or GHRPs, may not effectively identify GHD that is caused by hypothalamic disease, as they bypass the hypothalamic input.
Right, stimulating the wrong place.
Kind of. This is particularly relevant in patients who have received cranial irradiation, where the ITT often demonstrates greater sensitivity and specificity in detecting early GHD. These patients, as well as those with inflammatory or infiltrative paracellular lesions, require long-term follow-up and repeat testing, as GH deficiency can often develop insidiously years after the initial insult.
Are there other diagnostic approaches besides provocative testing that can aid in diagnosing GHD?
Yes, there are other methods, though they have their own limitations. GH-responsive markers like IGF-1 are useful for screening and monitoring, but a normal IGF-1 level doesn't definitively exclude GHD, especially in younger adults.
Okay, so it's helpful but not perfect.
Right. IGF-1 is also less reliable for diagnosis in patients over 50 due to the natural age-related decline in its levels. Measuring IGF-BP3 or the acid label subunit, which also relate to the GH axis, generally doesn't offer additional diagnostic advantage over IGF-1. While measuring spontaneous GH secretion over 24 hours can provide a comprehensive profile, it's cumbersome and generally considered inferior to provocative testing for diagnosis.
I can imagine.
And finally, emerging research is exploring gene expression analysis from blood samples, which may aid in diagnosing GH deficiency and assessing its severity, though its current utility for predicting linear growth or detecting GH abuse is still quite poor.
Finally, let's discuss growth hormone replacement therapy, its profound effects, and the critical considerations when treating patients. What are the key impacts of GH replacement?
GH replacement profoundly impacts protein, fat, and energy metabolism, driving significant and beneficial changes in body composition. It consistently leads to an increase in lean body mass and a corresponding decrease in fat mass, especially targeting reduction in abdominal and visceral adipose tissue, often without substantial changes in overall body weight.
Better body composition.
Exactly. It also significantly improves the lipoprotein profile, making it less atherogenic, which is a major cardiovascular benefit. Furthermore, GH increases extracellular water due to its anti-natriuretic properties, meaning it helps the body retain sodium and water.
And its effects on bone health. Is it beneficial for bone density?
Absolutely. GH replacement robustly activates bone turnover. Initially, this can lead to a transient decline in bone mineral density, but this is followed by a significant net increase in bone mass within 12 months, which can be sustained for up to 10 years, particularly in the lumbar spine.
10 years, that's significant.
It is. Observational studies have even reported a compelling 30% lower fracture incidence in patients on GH replacement compared to similar groups who remain untreated, strongly suggesting a long-term protective benefit against skeletal fragility.
So improved physical function and quality of life are also well-documented benefits.
They are indeed central to the benefits. GH replacement consistently improves physical function, enhancing both anaerobic and aerobic capacity and significantly increasing muscle strength. This improvement in physical capacity is intimately linked to a parallel and marked improvement in overall quality of life, particularly in critical domains like energy levels and emotional reactions.
Feeling better, doing more.
Precisely. Most clinical trials unequivocally report improved quality of life, and large observational surveys have even documented reductions in sick leave days and doctor visits, underscoring the broad positive impact on patients' daily lives.
How is GH replacement typically dosed for adults, and what are the targets for titration?
While the recommended starting doses are deliberately lower for older individuals, typically around 0.1 milligrams per day, for younger men it's generally 0.2 milligrams per day, and for women a slightly higher 0.3 milligrams per day is often recommended.
Okay, age and sex matter.
Definitely. Dosing is then meticulously titrated based on regular monitoring of serum IGF-1 levels. The goal is to maintain IGF-1 within the normal age and gender-matched reference range, while specifically avoiding levels in the upper quintile or above to minimize potential side effects. GH is administered nightly by subcutaneous injection to mimic the natural nocturnal secretion pattern, and side effects are generally fewer in children compared to adults who may experience more transient fluid retention.
Are there significant sex differences in the GH dosing requirements?
Yes, there are crucial sex differences that impact dosing. Women with GHD generally require higher doses of HGH, especially if they are receiving oral estrogen therapy.
Oral estrogen again.
Yes, this is due to that first-pass hepatic effect, where oral estrogen reduces the liver's production of IGF-1, which in turn enhances GH secretion through reduced negative feedback inhibition on the pituitary. In contrast, androgens tend to enhance GH's metabolic effects. These divergent effects of estrogens and androgens largely explain why women often appear less responsive to GH than men and require higher replacement doses.
What about patients transitioning from childhood GH treatment into adulthood? Should they continue treatment?
For children with GHD, GH treatment normally continues until final height is achieved and epiphyseal closure, the fusion of growth plates, occurs. However, it's now understood that these patients should generally continue GH treatment after puberty to complete the somatic maturation of muscle and bone, as normal adults continue to develop skeletal maturity into early adulthood.
So finish the whole maturation process.
Exactly. A significant proportion of childhood-onset GHD patients show a normal GH response when retested as young adults. So retesting for GHD in the adult phase is crucial unless they have a known transcription factor mutation or more than 3 confirmed pituitary hormone deficits, which typically indicate lifelong deficiency.
Let's address some important precautions and caveats when treating with human growth hormone. What are the common side effects patients might experience?
The most common side effects reported are edema, which is fluid retention and swelling, arthralgias or joint pain, and myalgias, which are muscle aches. However, it's important to note that these are generally mild, tend to be dose-related, and usually resolve either spontaneously or with a simple dosage reduction.
Usually manageable.
Generally, yes. While GH can antagonize insulin action, leading to some degree of insulin resistance, the overall risk of developing hyperglycemia or diabetes is very low in GHD patients, though it can be increased up to 8-fold in obese adults with GHD.
This raises an important question. What about cancer risk? That's a significant concern for any long-term therapy.
This is a critical and frequently asked question. Active malignancies are an absolute contraindication for initiating GH treatment. The theoretical concern is whether HGH could either initiate new cancers or stimulate the growth of existing benign tumors.
Right.
While fascinatingly, inactivating mutations of the GHR are associated with a markedly reduced incidence of cancer across the lifespan, and higher normal IGF-1 levels have been epidemiologically linked to an increased risk of prostate, breast, colon, and lung cancers, there is, to date, no evidence that GH replacement itself increases the risk of recurrence of pituitary adenomas or craniopharyngiomas in treated patients.
No evidence of increased recurrence, okay.
Right. In fact, some observational studies have even reported a reduction in cancer risk, although it's crucial to acknowledge that selection bias in these studies cannot be definitively ruled out. Nevertheless, the consensus remains that long-term surveillance with adequate control groups is absolutely required to fully assess the true incidence of new cancers or the growth of existing benign tumors in patients receiving GH replacement.
What about investigational uses of GH, perhaps in severe catabolic states or other challenging medical conditions?
The potent anabolic actions of GH have led to its investigation for use in severe catabolic states, such as after major surgery, trauma, extensive burns during parenteral nutrition, and in organ failure, with the aim of reducing negative nitrogen balance in critically ill patients.
Trying to help healing.
Exactly. While some beneficial effects on wound healing and protein balance have been reported in patients with extensive burns, there's also an increased risk of hyperglycemia. Importantly, a large study where critically ill patients received very high doses of GH, up to 15 to 20 times the normal daily production rates, was prematurely terminated due to a significant increased fatality rate in the treatment group.
Whoa, increased deaths. That's serious.
Very serious. This underscores the critical importance of caution and adherence to approved indications for GH use in adults. High doses in the wrong setting can be dangerous.
How about its investigational use in osteoporosis? Is there evidence it can improve bone mineral density?
There is strong evidence that GH, when administered to otherwise healthy subjects with idiopathic osteoporosis, can indeed improve bone mineral mass. An 18-month placebo-controlled study observed significant improvements in bone mineral content at the lumbar spine, femoral neck, and the whole skeleton by up to 14%, and these gains were sustained for a remarkable 4 years.
Sustained for years, okay.
However, concerns about unclear long-term side effects, the considerable cost of therapy, and the current lack of comparative studies with other established osteoporosis therapies limit its widespread clinical use solely for osteoporosis.
And its role in HIV infection, specifically HIV-associated cachexia.
GH is FDA approved for adults with HIV-associated cachexia, a severe wasting syndrome. Treatment results in a positive nitrogen balance, which means the body is building protein rather than breaking it down, along with increased lean body mass, decreased body fat, and improved work output.
Sounds beneficial there.
It can be. While high doses of GH have been shown to impair glucose tolerance in these patients, physiologic dosing, aimed at maintaining IGF-1 in the high normal range, has reported beneficial body compositional changes of a lesser magnitude, reduced triglycerides, and lowered diastolic blood pressure, though it can still mildly impair glucose tolerance. While a GH-releasing factor analog also showed promise, long-term beneficial effects of GH on overall survival and quality of life in HIV-infected individuals have not yet been conclusively reported.
Okay, let's unpack this for our listeners.
Yeah.
There's a lot of disease-mongering or commercial hype around GH as an anti-aging hormone. What's the truth behind these claims?
This claim is rampant in popular culture, but is fundamentally unsubstantiated by scientific evidence. It's primarily based on a superficial observation.
No.
The body composition changes that accompany the physical decline of aging things, like decreased lean mass and increased fat mass, bear a superficial resemblance to features seen in adults with organic GHD.
The comparison is tempting, I guess.
It is, but it's misleading. A comprehensive systematic review of randomized controlled trials in otherwise healthy elderly individuals unequivocally indicates that GH supplementation in this population leads to only very small, clinically insignificant changes in body composition. Crucially, it demonstrates no functional or cognitive benefit whatsoever.
No benefit.
And even more critically, it shows increased rates of adverse events. Given the increasing epidemiological evidence for the oncogenic potential of GH and the striking observation that cancers are significantly reduced in people with inactivation of the GH receptor, there is a strong consensus that GH cannot and should not be recommended as an anti-aging therapy.
Right. The science just isn't there.
Exactly. It's a clear case where the science does not support the popular narrative.
Let's move to the ACTH axis, which is the body's critical stress and survival system. Corticotroph cells, as we learned, are among the earliest detectable human fetal pituitary cell types.
That's right. Corticotroph cells make up approximately 20% of the functional anterior pituitary cells and are remarkably detectable as early as the 8th week of gestation. They are primarily clustered in the central median pituitary wedge. Morphologically, they are large, irregularly shaped cells with prominent neurosecretory granules, and they stain strongly positive for periodic acid shift due to the rich carbohydrate content of the POMC-derived peptides they produce.
Oh.
In the presence of excess glucocorticoid, clinicians can observe characteristic hyaline deposits within these cells.
And the structure of POMC, or pro-opiomelanocortin, is quite complex, acting as a precursor to several important peptides.
Indeed. POMC is the primary 266 amino acid pre-pro-hormone translation product. It's a remarkable molecule because it encodes a whole family of peptides with corticotropic, opioid, and melanotropic activities.
3 different types of activity from one precursor.
Yes. The human POMC gene is located on chromosome 2p23, and it possesses different promoters for pituitary-specific versus peripheral expression. This differential regulation means that the resulting peptides are processed differently depending on the tissue, leading to distinct biological outcomes.
How are these corticotroph cells precisely regulated, especially considering their role in the stress response?
Corticotrophs express the CRH type 1 receptor, or CRHR1, on their surface. When CRH binds to this receptor, it triggers a signaling cascade that increases intracellular cyclic AMP, activates protein kinase A, and induces CREB-mediated transcription of the POMC gene.
Okay, CRH kicks it off.
Right. CRHR1 is not exclusive to the pituitary. It's also found in other crucial brain regions, including the neocortex and hypothalamus, highlighting the widespread nature of the CRH signaling system.
So POMC is then processed into these various active peptides, but which are the key ones for the ACTH axis?
Yes. The key products of POMC processing relevant to the ACTH axis include ACTH 139, the primary circulating form, and beta-lipotropin, LPH, which is further cleaved to yield gamma-LPH and beta-endorphin, an endogenous opioid.
Beta-endorphin, okay.
The ACTH itself can also be further cleaved into alpha-melanocyte-stimulating hormone and corticotropin-like intermediate lobe peptide, CLIP, though these are typically more relevant in other tissues or conditions. Several post-translational modifications, such as glycosylation and phosphorylation, are absolutely required for the ultimate secretion of these mature polypeptide hormones and for their full biological activity.
Is POMC expressed only in the pituitary, or is it found in other tissues as well?
No, POMC is expressed quite broadly outside the pituitary. You can find it in the hypothalamus, the gonads, the lung, the skin, various gastrointestinal and adrenal medullary neuroendocrine cells, and even in white blood cells, highlighting its diverse roles.
Wow, everywhere.
Pretty much. In the hypothalamus, for example, POMC expression is stimulated by glucocorticoids, which paradoxically enhances the production of beta-MSH, a peptide that suppresses appetite.
Wait, glucocorticoids suppress appetite via POMC. That seems backwards.
It is a fascinating feedback loop, I agree. Leptin, the satiety hormone, and insulin also enhance hypothalamic POMC gene expression, linking energy status to appetite regulation through this pathway.
The control of ACTH secretion is described as complex, profoundly reflecting its role in our body's stress response.
It is indeed a testament to its critical function in survival. Its control is subserved by at least three intricately connected tiers. First, the brain and hypothalamus release a symphony of regulatory molecules, primarily CRH and vasopressin, but also dopamine, which directly regulate corticotroph function via that specialized hypothalamic portal system.
Okay, the top-down control.
Right. Second, intrapituitary cytokines and growth factors provide crucial local regulation, often overlapping and finely tuning the ACTH response to prevent chronic hypersecretion. And third, glucocorticoids themselves maintain rapid and precise negative feedback control by quickly inhibiting both hypothalamic CRH release and pituitary ACTH secretion.
The classic feedback loop.
Exactly. This includes a short feedback loop where pituitary ACTH inhibits hypothalamic CRH, and even an ultra-short loop where ACTH may directly suppress the corticotroph cell that produced it.
Here's where it gets really interesting and profoundly impacts our overall health. The HPA axis isn't just a stress responder. It's described as a critical component of a circadian system. What does that mean for us in our daily lives?
This is fundamental to our well-being. It means the HPA axis is an integral part of our body's internal 24-hour rhythm, meticulously regulating processes like substrate metabolism, immune function, cognitive performance, and our physiological adaptation to stress through the rhythmic secretion of glucocorticoids.
The body-clock connection.
Exactly. The master circadian pacemaker, which resides in the suprachiasmatic nucleus of the hypothalamus and is cued primarily by light-dark and feeding cycles, entrains virtually all our peripheral clocks. These peripheral clocks exist in tissues like the heart, kidney, muscle, liver, pancreas, blood, fat, and the adrenal gland itself.
Wow.
This entrainment largely occurs through neural and hormonal systems, with the HPA axis being a primary conduit. The physiologic effects of glucocorticoids are optimized when the central signal that controls the rhythm of glucocorticoid release and the peripheral rhythms in tissues are aligned.
Alignment is key.
Yes. For instance, that early morning peak of cortisol prepares us for physical activity, while declining levels later in the day optimize insulin sensitivity, preparing us for sleep and repair.
So if our modern lifestyles disrupt this natural alignment, there must be serious health consequences.
Absolutely. Modern lifestyles, characterized by things like shift work, frequent jet lag, and irregular meal times, cause what we call circadian misalignment.
Right, messing up the rhythm.
And this consistently leads to adverse health outcomes, particularly impaired substrate metabolism and worsened glucose tolerance. This occurs because there's an asynchrony between our meal times and the natural cortisol rhythm. It profoundly highlights how critical our internal clock is for maintaining metabolic health.
And the action of glucocorticoids, like cortisol, is mediated by two specific types of receptors.
Yes. Their action is mediated by mineralocorticoid receptors, or MIRs, and glucocorticoid receptors, or GRs. A crucial distinction is that glucocorticoids bind to MIRs with a tenfold higher affinity than they do to GRs.
Tenfold higher affinity for MIRs.
Right. This difference in affinity creates a sophisticated system for concentration-dependent activation of these receptors, providing a mechanism for the cell to decode the glucocorticoid action, especially with the pulsatile signal of cortisol shifting throughout a circadian cycle. This allows for nuanced biological responses depending on the precise cortisol concentration and the receptor type engaged.
And it seems that standard treatment regimens for adrenal insufficiency often don't truly mimic this natural ultradian rhythm.
That's a critical clinical challenge. The ultradian dynamics, the rapid pulsatile fluctuations of glucocorticoids, are fundamentally altered in many disease states. And significantly, they are largely abrogated or suppressed by the standard regimen of synthetic glucocorticoid replacement treatment.
So the standard pills flatten the rhythm.
Pretty much. This is a major insight that may explain why the conventional, relatively flat glucocorticoid replacement therapy often fails to fully restore physical, metabolic, and psychological well-being among patients with adrenal insufficiency. It doesn't replicate the intricate, natural 24-hour rhythm of cortisol concentration, which is so crucial for optimal physiological function.
Let's touch on melanocortin receptors, or MCRs. The source lists 5 types with distinct tissue distributions and fascinating actions.
These receptors are quite diverse. For instance, MC1R is found primarily in skin and hair follicles. ACTH and other POMC peptides activate MC1R, which is responsible for inducing skin pigmentation, as vividly seen in conditions like Addison disease.
The tanning effect in Addison's.
Exactly. Variations in the MC1R gene are also strongly associated with red hair color, fair skin, and a poor ability to tan. And a truly intriguing observation is that UV light stimulates skin melanocytes to produce POMC locally, which then increases local alpha MSH and beta endorphin.
Local endorphins from UV.
Yes. This local pollanendorphin production alleviates pain and is thought to contribute to UV-seeking addictive behavior, connecting skin exposure to brain reward systems.
That's a remarkable link between sun exposure and addiction. What about MC2R?
MC2R is exclusively found in the adrenal cortex, which is its primary site of action. This receptor crucially requires a protein called MRAP, or melanocortin-2 receptor accessory protein, to successfully traffic to the cell surface and function correctly. Mutations in MRAP are known to cause familial glucocorticoid deficiency. Activation of MC2R by ACTH directly results in the production of adrenal glucocorticoids, androgens, and to a lesser extent, mineralocorticoids. ACTH signals via adenyl cyclase to regulate the transcription of key P450 enzymes essential for the synthesis of these steroids, and it also stimulates mitochondrial cholesterol transport and cleavage, which is the rate-limiting step in steroidogenesis.
Got it.
The adrenal cortisol response is highly sensitive to the ambient ACTH milieu and can even be primed for a more robust response by prior ACTH exposure.
When it comes to measuring ACTH in a clinical setting, plasma assays are generally highly specific and sensitive.
Yes, current two-site immunometric assays for plasma ACTH offer high specificity and analytical sensitivity, allowing for precise measurement. However, it's worth noting that significant variability in precision can still exist between different commercial assays.
You need to be aware of the specific assay.
Right. For optimal blood collection, the subject should be non-stressed and resting, with samples ideally drawn between 6 and 9 a.m. to capture the natural circadian peak. ACTH is relatively unstable ex vivo, so samples require immediate separation of plasma in iced EDTA tubes and storage below 9-20 degrees C to preserve integrity.
Handle with care.
Definitely. Morning levels are typically in the range of 8 to 25 nanograms per liter, but they are known to fluctuate widely and rapidly due to episodic secretion and its short circulating half-life.
What are the primary causes of ACTH deficiency, both congenital and acquired?
Congenital ACTH deficiency can occur as an isolated pituitary defect, most commonly due to mutations in the TBX19 gene, which encodes TPIT, a crucial transcription factor involved in corticotroph differentiation.
Okay, TPIT.
It can also be part of more complex, multiple pituitary hormone deficiencies linked to mutations in genes like LHX4 and HESX1. A new syndrome recently proposed is David syndrome, deficient anterior pituitary function and variable immune deficiency, which has been linked to NFKB2 mutations.
Immune connection.
Yes. Acquired causes of ACTH deficiency are more common and include pituitary tumors, various sellar mass lesions, head trauma, cranial irradiation, and forms of hypophysitis, which can be autoimmune or, increasingly, induced by immune checkpoint inhibitors used in cancer therapy.
And what are the clinical features of ACTH deficiency? Are they distinct from other types of adrenal insufficiency, for example, primary Addison disease?
Clinically, the manifestations of ACTH deficiency are broadly indistinguishable from glucocorticoid deficiency caused by any other reason, and their severity depends on the degree of deficiency, the age of onset, and the clinical context. In newborns, it might present as severe hypoglycemia and failure to thrive. In adults, it often manifests as a slowly progressive weight and appetite loss, generalized anorexia, and pervasive fatigue, sometimes mimicking a wasting syndrome.
Vague symptoms again.
Very. Crucially, compared to primary Addison disease, what is absent in ACTH deficiency is salt wasting, volume contraction, and hyperkalemia, because mineralocorticoid secretion from the adrenal gland is largely unimpaired in secondary adrenal insufficiency.
Aldosterone is okay.
Generally, yes. Also, there is no hyperpigmentation, as that clinical sign is typically due to the exuberant secretion of ACTH-related peptides in the face of primary adrenal damage, which is not the case in ACTH deficiency.
How is ACTH deficiency accurately evaluated and then managed with replacement therapy?
Diagnosis requires the concurrent measurement of both morning serum cortisol and plasma ACTH levels. A morning serum cortisol level below 3 micrograms per deciliter strongly suggests deficiency, while a level above 18 micrograms per deciliter usually indicates normal adrenal reserve.
Okay, the 3 and 18 rule.
Kind of, but it's important to consider that cortisol-binding globulin levels can confound interpretation, so free cortisol measurement is often preferred. Provocative tests are necessary for confirmation. The insulin tolerance test, ITT, remains the gold standard for evaluating the entire HPA axis integrity.
ITT again.
Yep. The Matirapone test is an alternative for hypothalamic HPA axis evaluation, working by inhibiting the 11-hydroxylase enzyme, leading to an increase in 11-deoxycortisol. Pituitary ACTH stimulation tests, evoked by intravenous CRH or AVP, are also used to measure ACTH and cortisol responses, though their diagnostic utility can be limited by wide variations in response.
And for adrenal steroid replacement, what are the current best practices?
Hydrocortisone is the most widely used replacement steroid, with a typical total daily dose of 15 to 20 milligrams, which approximates the normal physiological cortisol secretory rate. Because cortisol's plasma half-life is relatively short, less than 2 hours, a 3 times daily dosing regimen is generally recommended to mimic the natural circadian rhythm more closely. For example, 5 to 10 milligrams in the morning, 2.5 to 5 milligrams at noon, and 2.5 to 5 milligrams in the evening.
Splitting the dose.
Right. Alternatives like prednisolone or dexamethasone with longer half-lives can be given once daily, but are harder to monitor for physiological replacement. Crucially, mineralocorticoid replacement, such as fludrocortisone, is not required for secondary hypoadrenalism, as aldosterone secretion is largely preserved. Dehydroepiandrosterone, DHEA, at 25 milligrams per day may be considered as an adjunct, as it has been shown to improve well-being, fatigue, and sexual function in some patients.
What's fascinating here is that despite these careful regimens, many patients still report a poor quality of life. Why is that if we're replacing the hormone?
This is a critical insight into the limitations of conventional therapy. The reason is that standard conventional regimens do not accurately recapitulate the physiological ultradian and circadian cortisol release pattern.
Doesn't match the natural rhythm.
Exactly. This fundamental mismatch may explain the high prevalence of persistent poor quality of life, as well as complications like osteoporosis in these patients. However, there have been significant advances with modified release formulations, such as Duocort, a dual-release hydrocortisone tablet.
Newer options.
Yes. Clinical trials have shown that this novel formulation can significantly improve weight management, glucose control, blood pressure, overall metabolism, immune function, and importantly, quality of life, precisely by mimicking the natural diurnal cortisol profile. This is a significant step towards more physiological replacement.
There's a truly crucial precaution regarding thyroid hormone replacement in patients with suspected ACTH deficiency that we absolutely must emphasize.
This is perhaps one of the most vital clinical warnings in pituitary management. Thyroid hormone replacement should only be initiated after adrenal status has been thoroughly evaluated and, if necessary, treated in pituitary patients suspected of having ACTH deficiency.
Adrenals first, always.
Always. The reason is profound. Thyroid hormones accelerate the metabolism of cortisol. If a patient with underlying undiagnosed ACTH deficiency is given thyroid hormone without adequate cortisol replacement, it can rapidly deplete their already compromised cortisol reserves and potentially precipitate a life-threatening adrenal crisis. Always address the adrenal axis first.
And finally, a brief mention of ACTH excess.
ACTH excess, while less common than deficiency, is typically caused by ectopic ACTH production from non-pituitary tumors, such as small cell lung cancers or carcinoid tumors.
Tumors making ACTH elsewhere.
Right. These tumors aberrantly produce high amounts of POMC. The resulting excessive ACTH then overstimulates the adrenal glands, leading to a profound syndrome of hypercortisolism and androgen excess, commonly known as Cushing disease, which causes significant morbidity due to the widespread effects of excess cortisol.
Let's move on to the gonadotropin axis, which involves LH and FSH and is absolutely central to reproduction and fertility.
Gonadotroph cells, which comprise about 10% to 15% of the anterior pituitary cells, are responsible for producing these vital hormones. They're a heterogeneous population, meaning not all are identical. Some cells are bihormonal, secreting both LH and FSH, while others are monohormonal, secreting only one.
Okay, some variety there.
Yes. These cells are specifically characterized by their expression of the GnRH receptor on their surface and key nuclear receptors like SF1 and DAX1, which are important for their development and function.
And the structure of LH and FSH is quite specific, involving two subunits.
They are heterodimeric glycoprotein hormones, meaning they are composed of two distinct protein subunits. They share a common alpha subunit, which is encoded on chromosome 6, but each has its own unique beta subunit. LH beta is on chromosome 19 and FSH beta is on chromosome 11.
Alpha common, beta unique.
Correct. This heterodimeric structure, along with meticulously positioned disulfide linkages, is absolutely essential for their biological activity and for facilitating their specific and precise ligand receptor interactions with their respective target cells.
So glycosylation, the addition of sugar chains, also plays a crucial role.
It is indeed critical. The post-translational processing involving carbohydrate side chains, or glycosylation, is vital for proper hormone signaling. This glycosylation pattern is distinct for LH and FSH and can vary physiologically, significantly influencing their bioactivity and their metabolic clearance rates in the body.
Okay.
The human LHCG gene cluster itself is a fascinating genetic region, comprising 7 genes, including one for LH and one for CG, chorionic gonadotropin, primarily placental in primates. These genes have different promoters, which accounts for their distinct tissue distribution. The HCG protein, notably, has a C-terminal extension that is crucial for its significantly longer biological half-life compared to LH.
That's why HCG lasts longer.
Exactly. FSH, encoded on chromosome 11, has a similar gene organization to other beta genes, encoding a mature peptide of 111 amino acids with 2 glycosylation sites, and is uniquely expressed only in gonadotrophs.
The regulation of LH and FSH is notably complex, integrating signals from 3 distinct levels.
Yes, it's a sophisticated interplay of hierarchical control. It includes, first, the central hypothalamic GnRH input, which is the primary driver. Second, intrapituitary paracrine factors like activin and follistatin, which modulate local responses within the pituitary. And third, peripheral feedback signals originating from gonadal sex steroids and various peptide hormones. This multi-level integration ensures finely tuned control.
And their secretion patterns change quite dramatically across the lifespan, don't they?
They exhibit fascinating developmental patterns. LH and FSH levels typically decline after birth due to negative feedback from fetal sex steroids. They then experience a transient rise around 2 to 3 months of age, before declining again to very low prepubertal levels by 6 months in boys and 1 to 2 years in girls.
The mini-puberty.
Exactly. This early postnatal period actually provides a valuable window to assess the integrity of the hypothalamic pituitary gonadal, or HPG, axis. After puberty, adults secrete gonadotropins in a distinct pulsatile fashion with much more dynamic cyclical regulation in females throughout the menstrual cycle. Levels then significantly increase in postmenopausal women, reflecting the loss of ovarian feedback, though a similar dramatic increase is not paralleled in men with aging, despite age-related declines in both sexes.
Okay, let's unpack this. Hypothalamic GnRH neurons are described as pivotal integrators of a vast array of peripheral signals. What genetic insights have we gained regarding their control of puberty and fertility?
This is a rapidly evolving area of knowledge stemming from insights into pubertal disorders and infertility, specifically GnRH deficiency or hypogonadotropic hypogonadism, ACTH. We've learned that hyperthalamic GnRH neurons are indeed the central integrators.
Right.
Conversely, mutations in genes like MKRN3 and DLK1 are now known to cause central precocious puberty by prematurely reactivating GnRH secretion, effectively lifting a natural brake on puberty.
Taking the brakes off too early.
Precisely. MKRN3, for instance, appears to act as a crucial repressor of GnRH secretion during childhood, often through its actions on kisspeptin neurons, keeping the reproductive axis dormant until the appropriate time.
So neurotransmitters also play a significant role in modulating GnRH release.
Many do. Neurotransmitters like norepinephrine and glutamate provide a stimulatory drive to GnRH neurons, essentially turning up the signal. Conversely, GABA and opioid peptides act as inhibitory signals, dialing it down.
Gas and brake.
Kind of. Critically, kisspeptins, which are peptides encoded by the KISS1 gene and their receptor, KISS1R, have been identified as truly key GnRH secretagogues. They are powerful activators of GnRH release.
Kisspeptins, okay? Heard a lot about those.
Yes. Administering kisspeptin can dramatically increase FSH, LH, and testosterone in men, and it robustly stimulates gonadotropin release in women. Neurokinin B, NKB, often co-expressed with kisspeptin in neurons, also modulates GnRH release, and MKRN3 appears to restrain both neurokinin B and kisspeptin production prepubertally. Leptin, the hormone from adipose tissue, is another crucial positive regulator, providing a direct link between body fat and energy availability to reproductive function.
Body fat talks to reproduction.
Directly. Nutrient sensing via the melanocortin-3 receptor also plays an important role. And finally, external factors like stress and circadian inputs all appear to channel their influence through kisspeptin neurons to modulate the entire HBG axis.
And the hallmark of GnRH secretion is its pulsatile nature. This seems to be absolutely critical.
It's vital. GnRH is not released continuously, but rather in a precisely timed pulsatile fashion into the hypophyseal portal circulation. This pulsatile pattern is the physiological key.
Pulses are everything.
Pretty much. In patients with GnRH deficiency, for example, exogenous pulsatile GnRH treatment can effectively restore normal gonadotropin secretion and fertility. However, if the same patients are exposed to continuous GnRH, it paradoxically suppresses gonadotropin secretion.
Continuous shuts it down.
Right. This highlights that the specific pattern of GnRH signaling, including its amplitude, frequency, and waveform contour, is crucial for the differential synthesis and secretion of LH and FSH, allowing the pituitary to produce the correct ratio of hormones for different reproductive stages.
What about inhibins and activins? How do these gonadopeptides influence FSH?
The hypothesis that a gonadopeptide selectively regulates FSH dates back to as early as 1932, but it took over 50 years to finally identify inhibin and related peptides.
Wow, long time coming.
Yeah. Inhibins are dimeric proteins that selectively and potently regulate FSH secretion by inhibiting its production. Conversely, activins, which are formed by the dimerization of beta subunits, act to stimulate FSH synthesis and secretion. Furthermore, follistatin, a structurally unrelated monomeric polypeptide, also inhibits FSH release by binding to activins and directly interfering with their receptor binding.
Follistatin blocks activin.
Correct. Inhibins themselves also compete for activin receptor binding, thereby blocking activin signaling at the pituitary. It's a complex interplay.
And sex steroids, estrogens, progesterones, and androgens clearly affect gonadotropins. How do they do that?
They influence gonadotropins through a dual mechanism. They act directly at the gonadotroph level, as receptors for these steroids are present on the gonadotroph cells themselves, allowing for direct modulation of hormone production and release.
Direct action on the pituitary cells.
Yes. And critically, they also act indirectly via the hypothalamus, where they modulate GnRH secretion, especially through their profound influence on kisspeptin neurons, which are highly sensitive to sex steroid feedback. This integrated direct and indirect feedback ensures precise control of the reproductive axis.
Now let's look at the specific actions of LH and FSH in females, focusing on their roles in the ovarian cycle.
In females, LH acts primarily on the ovarian theca cells, stimulating the production of androgen precursors. These precursors then diffuse into the neighboring granulosa cells, where FSH plays a crucial role by stimulating their aromatization into estrogens.
Two-cell, two-gonadotropin system.
Exactly. LH also significantly increases cholesterol availability for steroidogenesis by inducing the star protein, and it enhances the activity of key steroidogenic enzymes. The mid-cycle LH surge is a critical event. It stimulates oocyte meiosis and maturation, initiates follicle rupture and ovulation, and precisely induces corpus luteum formation after ovulation.
The big surge triggers ovulation.
Right. Furthermore, LH promotes progesterone receptor expression and synthesis, which is vital for sustaining luteinization.
And for males, what are the distinct actions of LH and FSH in testicular function and spermatogenesis?
In males, LH acts specifically on the Leydig cells within the testes, inducing intratesticular testosterone synthesis, an action mediated by enhanced cyclic AMP production. FSH, in concert with the high intratesticular testosterone levels induced by LH, is absolutely critical for successful spermatogenesis, the production of sperm.
Need both LH and FSH for sperm.
You do. FSH binds to Sertoli cells, which are nurse cells in the testes, stimulating the production of inhibins, androgen-binding protein, and other crucial proteins. Ultimately, FSH mediates the maturation of spermatids into mature spermatozoa, working in close collaboration with testosterone.
When measuring gonadotropins, it seems that improved assays have resolved some prior challenges, leading to more accurate results.
That's certainly the case. Modern two-site immunofluorometric and immunochemiluminescent LH and FSH assays offer significantly better sensitivity and specificity compared to older methods, effectively resolving previous issues of cross-reactivity with other hormones. Alpha subunit assays are also used in specific clinical contexts.
And the GnRH stimulation test is often employed. How does it work, and what are its diagnostic utilities?
A single bolus of GnRH administered intravenously causes a rapid increase in serum LH and FSH levels, with LH typically rising more abundantly than FSH. In patients with hypogonadotropic hypogonadism, these responses are blunted or absent, and the LH-FSH ratio is often reversed.
Lower reverse response in HH.
Typically. However, it's important to acknowledge that its utility for definitively distinguishing hypothalamic from pituitary lesions in adults can be limited, though repetitive GnRH pulses can sometimes normalize responses in hypothalamic HH. The GnRH stimulation test is most frequently used to assess pubertal status, to diagnose HH, or to evaluate central precocious puberty. Alternatives like the leuprolide stimulation test and emerging kisspeptin stimulation tests are also being investigated and used in specific situations.
What are the various causes of gonadotropin deficiency, or hypogonadotropic hypogonadism, HH, both congenital and acquired?
HH can stem from either congenital or acquired causes. Congenital causes include a wide range of gene mutations affecting various aspects of GnRH neuron development or migration, the control of GnRH secretion, gonadotroph development, or the regulation of LH-FSH. Examples include conditions like Kalman syndrome, which involves impaired neuronal migration.
Okay, genetic roots.
Right. Acquired HH can result from functional disorders like severe stress, malnutrition, chronic illness, depression, excessive exercise, or dangerously low body weight. Drug-induced causes are also prevalent, including opiates, high-dose glucocorticoids, sex steroids, GnRH agonists-antagonists, tranquilizers, various antidepressants, and antipsychotics, some of which can also cause hyperprolactinemia, which in turn suppresses GnRH.
That drug list again.
Yeah, lots of overlap. Organic causes include malignant disease, developmental disorders affecting the hypothalamus or pituitary, tumors in the cellar or paracellar region, infiltrative diseases, head trauma, and damage to the hypothalamus or pituitary from surgery or radiotherapy. It can also be associated with autoimmune lymphocytic hypophysitis and hypophysitis induced by immune checkpoint inhibitors.
And what are the diverse clinical manifestations of HH? How do they differ based on the severity and age of onset?
The manifestations of hypogonadism vary significantly depending on its severity and the age of onset. In congenital females, it may present as unusually tall stature due to delayed epiphyseal closure, primary amenorrhea, and absent secondary sexual development.
Right, no puberty.
Essentially. Congenital males can present with delayed or absent puberty, a micropenis, undescended testes, cryptorchidism, and a eunuchoid habitus, also due to delayed epiphyseal closure. Generally, across all presentations, you'll observe low LH and FSH levels despite low sex steroid levels. In acquired HH in males, symptoms can include loss of body hair, persistent fatigue, muscle wasting, obesity, and profound loss of libido, potency, and fertility.
Significant impact on men later in life.
Definitely. Isolated deficiencies also have specific nuanced presentations. Isolated FSH deficiency, for example, typically leads to oligospermia, low sperm count, or azoospermia, absence of sperm, in males, and in females, it can cause delayed puberty, amenorrhea, or infertility. Isolated LH deficiency in males can manifest as delayed or absent puberty with unicoidal proportions, while in females it may result in normal puberty and menarche, but subsequent secondary amenorrhea and infertility, as LH is crucial for ovulation.
So how is fertility managed, and what about hormone replacement therapy for these patients who aren't seeking fertility?
For patients not seeking fertility, sex steroid replacement is the primary therapy. Its purpose is to induce and maintain primary and secondary sexual characteristics, and critically, to preserve healthy body composition, bone mineral density, and muscle mass.
Maintain normal adult function.
Exactly. When monitoring the adequacy of this steroid replacement, it's important to note that monitoring LH and FSH level is generally not effective, as basal gonadotropin levels are already suppressed or low due to the underlying HH.
What are the standard options for estrogen replacement in females with HH?
For females, various forms of estrogens are available. Initial therapy is typically estrogen alone to maximize breast growth, with progestin added later to prevent endometrial hyperplasia, but crucially, not before breast development is complete.
Sequence matters.
Yes. Oral or transdermal estradiol with cyclic progesterone is a common regimen. This therapy significantly helps reduce the long-term risk of osteoporosis. Potential side effects can include thromboembolic disease, breast tenderness, and possibly a slightly enhanced risk for breast cancer with prolonged use, though this is debated. Estrogen replacement is typically continued until around age 50, after which it's individualized based on a careful assessment of risks and benefits.
And for males, what are the androgen replacement options in their considerations?
For men, androgen replacement comes in various formulations, including intramuscular injections, transdermal gels, patches, subcutaneous implants, and even nasal or oral preparations. Transdermal gel systems and patches are often favored as they offer sustained, stable testosterone levels, closely mimicking physiological secretion.
More steady levels.
Right. Intramuscular injections are an alternative, usually given every 2 to 3 winks, or lower doses more frequently to minimize fluctuations. Oral forms are generally not recommended due to inconsistent absorption and potential hepatotoxicity. Side effects can include acne, gynecomastia, prostatic hypertrophy, and polycythemia. While there's no strong evidence that testosterone replacement directly causes prostate cancer, it can exacerbate benign prostatic hypertrophy, so it should generally be avoided in men with diagnosed prostate cancer.
Now, for fertility goals, what specific therapies are employed to induce ovulation or spermatogenesis in patients with HH?
For patients with normal pituitary function but GnRH deficiency, such as those with idiopathic HH or Kallmann syndrome, pulsatile GnRH therapy is an excellent alternative. It involves subcutaneous infusion of GnRH by a mini pump to maintain normal physiological gonadotropin and testosterone levels.
Mimicking the natural pulses.
Exactly. This approach can be more effective than gonadotropin injections and may cause less gynecomastia, though it requires strong patient commitment, as spermatogenesis can take 2 years or even more to fully establish. For males, sperm freezing is often recommended as a precautionary measure. Clomiphene citrate, a weak estrogen receptor antagonist, also stimulates gonadotropin secretion and is used for men with partial hypogonadotropism and oligospermia or azoospermia.
And specifically for women with HH seeking fertility.
For women with HH, both pulsatile GnRH administration or gonadotropin therapy can effectively induce ovulation. While gonadotropins often lead to high rates of multiple follicle development, GnRH therapy may reduce the incidence of multiple gestations if the patient has sufficient residual pituitary gonadotroph reserve.
Maybe fewer multiples with GnRH.
Potentially. What's fascinating here, and an active area of current investigation, is the potential for kisspeptin or kisspeptin analogs to further reduce the chances of multiple gestations or the risks of ovarian hyperstimulation in assisted reproduction, offering a more refined control over follicle development.
Kisspeptin, again, interesting potential.
Yes. Additionally, GnRH antagonists are now widely available and used in assisted reproduction, as well as for treating conditions like endometriosis, uterine leiomyomas, and for palliation of metastatic prostate cancer.
Let's talk about the TSH axis, which is a fundamental regulator of development, growth, and metabolism throughout life.
Thyrotroph cells, which comprise approximately 5% of the anterior pituitary cells, are responsible for producing TSH. They are typically located anteromedially within the gland, are smaller than other cell types, and contain characteristic small secretory granules that store TSH. Thyrotrophs are detectable in the fetal pituitary by 12 weeks of gestation, and their precise differentiation is critically dependent on the coordinated action of transcription factors like GATA2, POU1F1, and PROP1 during development.
And the structure of TSH is quite unique, being a heterodimer of two subunits.
Yes, TSH is a 28 kilodalton heterodimer composed of two non-covalently linked subunits, an alpha subunit and a beta subunit. While the alpha subunit is common to TSH, LH, FSH, and HCG, meaning it's shared across these different glycoprotein hormones, the beta subunit is unique to TSH and is what confers its specific biological activity and receptor specificity.
Beta gives the specificity.
Correct. Genetically, the alpha subunit gene is the earliest hormone gene expressed embryonically. Its regulation is cell-specific, enabling its expression in the placenta, gonadotrophs, and thyrotrophs. The TSH beta subunit gene expression, however, occurs later in development and is significantly influenced by the GATA2 and PO1F1 transcription factors.
In glycosylation, the addition of sugar chains is important here too.
It is absolutely essential. Complex co-translational glycosylation, meaning the addition of sugar chains as the protein is being made, and the proper folding of the nascent alpha and beta subunits within the endoplasmic reticulum and Golgi apparatus are critical for the production of the mature, biologically active heterodimeric TSH molecule. This intricate post-translational modification also influences TSH's metabolic clearance rate and its overall bioactivity.
How is the TSH axis meticulously regulated by the brain and peripheral hormones?
The regulation is highly precise. The transcription of both the alpha subunit and TSH beta genes is potently inhibited by the thyroid hormone receptor, TR, acting in concert with core pressors. This suppression is remarkably rapid, evident within 30 minutes of T3 exposure, and represents a critical determinant of ultimate TSH secretion.
Fast feedback.
Very. Both gene transcriptions are also robustly induced by TRH and suppressed by dopamine. Furthermore, both TRH and T3 also meticulously regulate TSH glycosylation, albeit in opposite directions. TRH exposure or T3 deprivation enhances oligosaccharide addition to the TSH molecule, increasing its biological half-life and bioactivity.
What's fascinating here and truly central to understanding thyroid regulation is the role of the TRH neuron in the periventricular nucleus, setting the precise set point of the entire hypothalamic pituitary thyroid axis.
This TRH neuron is a master integrator of physiological stimuli. For example, it receives crucial adrenergic input from the medulla, which mediates the robust stimulatory effects of cold exposure on thyroid hormone production.
Cold stimulates TRH.
Yes. It also receives direct projections from the arcuate nucleus. Leptin-responsive POMC neurons activate TRH neurons, while NPY-AGRP neurons inhibit them. This is a vital link between energy status and thyroid function. For instance, fasting significantly reduces TRH expression by suppressing the POMC system and stimulating the NPY-AGRP system. Additionally, the dorsomedial nucleus projects to the paraventricular nucleus, providing yet another pathway for leptin to regulate TRH neurons, highlighting the intricate neuroanatomic control.
And TRH can actually be inactivated even before it reaches the pituitary, right?
Yes, this is a sophisticated local control mechanism. TRH can be inactivated by specific peptidases, notably pyroglutamyl peptidase 2, which are present in the membrane of tannocytes.
Tannocytes, these specialized cells again?
Exactly. Tannocytes are specialized cells lining the third ventricles of the brain, strategically positioned to interact with the cerebrospinal fluid and portal system. The activity of these TRH inactivating peptidases is notably enhanced by both fasting and by a hyperthyroid state, providing an additional layer of negative feedback and metabolic adaptation.
What about thyroid hormone receptors and deadenases? What roles do they play in thyroid hormone action and regulation?
Thyroid hormone receptors, TRα and TR-beta, are nuclear hormone receptors. TR-beta 2 is recognized as the key isoform responsible for the precise T3-mediated negative feedback regulation, specifically on TRH neurons in the hypothalamus. Mutations in TRs can lead to syndromes of thyroid hormone resistance, where the body's tissues don't respond adequately to circulating thyroid hormone.
Okay, receptor resistance.
Right. Deadenases are a family of enzymes that meticulously metabolize thyroid hormones, determining the local T3 availability within various tissues. Deadenase 2, or D2, is crucial as it activates T4 to its more potent form, T3, and is expressed in hypothalamic glial cells and tannocytes, contributing significantly to negative feedback. Deadenase 3 inactivates both T4 and T3, while deadenase 1 can both activate and inactivate depending on the context.
And thyroid hormones don't just passively cross cell membranes, they need transporters.
That's absolutely correct, and it's a critical, often overlooked detail for their action. Thyroid hormones do not passively cross cell membranes. They require specific transport into cells, facilitated by three main classes of thyroid hormone transport proteins: monocarboxylate transporters, MCTs, organic anion transporters, OATP, and L-type amino acid transporters, LE2.
In a specific doorway.
Exactly. MCT8, for example, shows a strong preference for T3, and fascinatingly, mutations in the MCT8 gene in humans cause severe neurological abnormalities associated with a very specific biochemical profile: elevated T3 levels, decreased T4 levels, and normal TSH secretion. This vividly underscores the critical and indispensable role of these transporters for proper thyroid hormone action in specific tissues like the brain.
Let's discuss TSH secretion patterns and the transformative impact of modern TSH assays.
Daily TSH production is approximately 100 to 400 milliunits, and it has a circulating half-life of about 50 minutes. TSH secretion rates are significantly enhanced in hypothyroidism, where the body tries to compensate, and suppressed in hyperthyroidism. The degree of TSH glycosylation, influenced by TRH and T3, also affects its metabolic clearance rate and bioactivity. TSH secretion is pulsatile, but its low pulse amplitudes result in only modest circulating variances in healthy individuals. These variances are amplified in hypothyroidism and abrogated in critical illness. Its circadian peak naturally occurs between 11 p.m. and 5 a.m.
And TSH assays have truly revolutionized diagnostic evaluation, making the TRH test obsolete for hyperthyroidism.
Absolutely. The widespread availability of ultra-sensitive immunologic two-site assays, specifically third-generation TSH assays, has been a game-changer in diagnostics. They offer unparalleled sensitivity and specificity, providing clear discrimination between hyperthyroid, euthyroid, normal thyroid function, and hypothyroid states.
Much better tests now.
Much better. This precision has, in fact, rendered the TRH test largely obsolete for diagnosing thyrotoxicosis, as the basal TSH level alone is usually sufficient for diagnosis.
But TSH measurement alone isn't sufficient for diagnosing central hypothyroidism, is it?
No, it's a critical distinction. For central hypothyroidism, measuring TSH alone is not helpful as a primary diagnostic tool. This condition is identified by concurrently low circulating T4 levels alongside TSH levels that can be low, normal, or even minimally elevated.
Low T4 with inappropriate TSH.
That's the key profile. This biochemical picture can also be seen in critically ill patients without pituitary disease, making careful clinical correlation essential. The TRH test, while used for some other pituitary evaluations, does not reliably aid in diagnosing central hypothyroidism.
What are the causes of TSH deficiency, both congenital and acquired?
Congenital isolated TSH deficiency can arise from mutational defects in the TSH or TRH receptor genes, highlighting genetic predispositions. TSH deficiency can also be a component of more complex multiple pituitary hormone deficiencies resulting from genetic disorders of pituitary gland development involving genes like LHX3, PROQ1, and POU1F1. Beyond these developmental issues, direct pituitary damage from various causes, such as tumors, surgery, or radiation, can also lead to functional TSH deficiency.
And the manifestations are essentially those of thyroid hormone deficiency.
That's correct. The clinical consequences of TSH deficiency are ultimately those of inadequate thyroid hormone, leading to significant childhood mental and growth retardation if untreated, and in adults presenting with a constellation of clinical features very similar to primary hypothyroidism, such as fatigue, weight gain, and cold intolerance.
How is it treated, and how do we guide the dose, since TSH isn't a reliable marker here?
L-thyroxine is the standard treatment for replacement therapy. The dosing is carefully titrated to achieve mid-normal free T4 levels, as TSH itself cannot be used to guide dose titration in secondary hypothyroidism because the damaged thyrotroph cells in the pituitary won't adequately reflect the negative feedback suppression from administered thyroid hormone.
So you target the free T4 instead.
Exactly. We rely on the peripheral hormone levels to ensure adequate replacement.
This raises an important question. What happens to TSH levels during growth hormone therapy? Is there an interaction?
This is a critical clinical interaction. Growth hormone actually stimulates the conversion of T4 to T3. Therefore, during GH therapy for GHD, especially in patients who may have borderline thyroid function or undiagnosed central hypothyroidism, blood-free T4 levels may fall into the subnormal range.
GH can lower T4.
Effectively, yes, by increasing conversion to T3. This can effectively unmask central hypothyroidism, necessitating concurrent thyroid hormone supplementation to prevent the symptoms of deficiency. It's a reminder of how interconnected these hormonal axes are.
And a crucial precaution we've mentioned before, but it bears repeating, initiating thyroid hormone replacement in pituitary patients suspected of ACTH deficiency.
Absolutely. This cannot be overemphasized. Thyroid hormone replacement should only be initiated after adrenal status has been thoroughly evaluated and, if necessary, treated in any pituitary patient suspected of ACTH deficiency.
Still adrenals first.
Still adrenals first. The profound reason is that thyroid hormones accelerate cortisol metabolism. If a patient has unmanaged adrenal insufficiency, starting thyroid hormone could rapidly deplete their already compromised cortisol reserves and precipitate a life-threatening adrenal crisis. Always prioritize the adrenal axis.
Finally, quick note on TSH excess.
TSH excess is rare compared to deficiency, but it can arise from a few distinct causes. TSH-secreting pituitary adenomas, which are benign tumors producing too much TSH. Thyroid hormone resistance due to mutations in the TRELFA or KIR-beta receptors, where the body's tissues don't respond to normal thyroid hormone levels, or TSH receptor resistance in the thyroid gland itself. These conditions are typically distinguished through a combination of detailed familial history, advanced imaging, thorough clinical examination, and specific TRH testing.
Now, let's bring all this incredible detail together and discuss pituitary failure itself, its various causes, how we diagnose it, and its comprehensive management. Let's start with the increasingly understood genetic and heritable causes.
It's a profound area of discovery. We now understand that mutations can occur at virtually every level of pituitary function, in the hormones themselves, their receptors, and crucially, in the transcription factors that are vital for the proper development of the anterior pituitary. Any of these mutations can lead to complex pituitary deficiency syndromes. Furthermore, isolated single hormone deficiencies, such as those involving GH, POMC, TSH-beta, LH-beta, and FSH-beta, can often result from highly specific gene mutations.
So, many previously idiopathic cases of pituitary failure are now finding their explanation in specific genetic mutations.
Precisely. As our understanding of the intricate transcriptional control of pituitary development expands rapidly, an increasing number of mutant genes are being identified as the molecular cause of what were previously considered idiopathic or unknown, isolated, or polyhormonal pituitary failures. This is transforming our diagnostic capabilities.
What's fascinating here, and truly allows for a deeper understanding, is how specific transcription factor mutations lead to very distinct syndromes. Let's dive into some prominent examples, starting with HSX1.
HSX1 is an early and critical transcriptional marker of the primitive pituitary. Mutations in HESX1 are strongly associated with septo-optic dysplasia, a heterogeneous syndrome characterized by the hypoplasia or underdevelopment of the optic nerves, the absence of the corpus callosum and septum pellucidum in the brain, and a variable degree of hypopituitarism.
Variable, okay.
Yeah, which can range from full panhypopituitarism to an isolated GHD. It's also specifically linked to pituitary stalk interruption syndrome.
And SOX2 and SOX3, what are their roles?
SOX2 mutations are also associated with septo-optic dysplasia, as well as severe eye abnormalities like anophthalmia, absence of eyes, or microphthalmia, small eyes, and anterior pituitary hypoplasia, frequently presenting with hypogonadotropic hypogonadism, HH, and GHD, alongside other forebrain developmental defects.
Eye problems common with these.
Often, yes. SOX3 mutations are linked to X-linked hypopituitarism and mental retardation, typically affecting males, causing GHD and potential deficiencies in gonadotropins, TSH, or ACTH. The precise dosage of SOX3 protein appears to be critically important for normal pituitary development. Too little or too much can cause problems.
What about OTX2?
Mutations in OTX2 have been implicated in ophthalmia microphthalmia syndromes in humans, often leading to severe ocular and neurological phenotypes, including developmental delay and seizures. Panhypopituitarism, or deficiency of all pituitary hormones, can occur, possibly due to a failure of OTX2 to activate the transcription of other essential genes like HESX1 and POU1F1.
Then there are LHX3 and LHX4, which have distinct but sometimes overlapping pituitary effects.
LHX3 mutations cause multiple anterior pituitary hormone deficits, affecting all axes with the notable exception of a largely intact ACTH reserve. These patients often also exhibit a distinctive defective neck rotation ability due to a rigid cervical spine and can have variable sensorineural hearing loss, indicating broader developmental impacts.
Stiff neck and hearing loss. Interesting.
Yes, LHX4 mutations cause GHD and short stature with variable additional endocrine deficits, particularly TSH and ACTH deficiency. These mutations are also associated with anterior pituitary hypoplasia and an ectopic or abnormally located posterior pituitary.
And the PITX genes, PITX1 and PITX2.
PITX1 and PITX2 show high homology and overlapping expression patterns during pituitary development, underscoring their related roles. PITX1 is expressed across all 5 anterior pituitary cell lineages, highlighting its broad importance. Mutations in PITX2 specifically cause Riger syndrome, a condition characterized by distinct defects in the eyes and teeth, a protuberant umbilicus, and importantly, pituitary hormone deficiencies.
PLP1 mutations are highlighted as the most common genetic cause of combined pituitary hormone deficiency, or CPHD. That's a key genetic insight.
This understanding first came from studies of the Ames-Dwarf mouse model. In humans, PRP1 mutations typically lead to deficiencies in the PO1F1 dependent lineages, that is, GH, and TSH.
The ones PIT1 controls.
Exactly. Additionally, impaired FSH and LH secretion resulting in delayed or absent puberty, hypogonadotropic hypogonadism, and infertility is also very frequently present. It's important to note that ACTH deficiency, while often associated, can have a later onset, emphasizing the need for continued clinical assessment over time. The overall clinical picture or phenotype is quite variable and temporal depending on the specific mutation type and the patient's age.
And POU1F1, or PIT1 itself, what happens with inactivating mutations here?
POU1F1 encodes PIT1, a crucial protein that directly activates the transcription of genes for GH, PRL, TSH-beta, and the GHRH receptor. Inactivating mutations in POU1F1 cause a spectrum of pituitary hormone deficiencies primarily affecting somatotroph, lactotroph, and thyrotroph development, as famously observed in the Snell and Jackson dwarf mouse strains.
Right, the classic dwarf mice.
Yep. Interestingly, adult-onset deficiencies affecting these same hormones can sometimes be associated with autoantibodies directed against the PIT1 protein, suggesting an autoimmune component in some cases.
And IGSF1, what does loss of function here cause?
Loss-of-function mutations in the IGSF1 gene cause X-linked congenital central hypothyroidism. This condition is often accompanied by variable PRL deficiency, GHD, and curiously, testicular enlargement.
Testicular enlargement, that's unusual.
It is. This constellation of symptoms implies impaired pituitary TRH signaling as a core defect, highlighting the broader role of IGSF1 in pituitary axis regulation.
TBX19 and its connection to David syndrome sounds intriguing.
TBX19 mutations, also known as TPIT mutations, are recognized as the principal molecular cause of congenital neonatal isolated ACTH deficiency and hypocortisolism, leading to a very early onset isolated ACTH deficiency, usually presenting in newborns.
Isolated ACTH deficiency from birth.
Right. Associated phenotypes can include obesity and red hair pigmentation. The David syndrome, which stands for deficient anterior pituitary function and variable immune deficiency, was proposed for patients presenting with ACTH deficiency and variable immune deficiencies, with the NFKB2 gene recently implicated as the transcription factor responsible for this broader syndrome.
What about NR5A1, or SF1, and NR0B1, or DAX1? These sound like key regulators of the reproductive and adrenal axis.
NR5A1 encodes SF1, a key transcriptional regulator that plays a vital role in the reproductive axis and adrenal gland development and function. Mutations in NR5A1 can lead to varying degrees of XY sex reversal, gonadal defects, adrenal failure, and hypogonadotropic hypogonadism.
Like broad effects.
Yes. Similarly, NR0B1 encodes DAX1, a related nuclear receptor transcription factor. Mutations in NR0B1 cause X-linked hypogonadotropic hypogonadism and adrenal hypoplasia congenita. What's particularly interesting, almost a biological contradiction, is that despite SF1 generally acting as an activator and DAX1 as a repressor, loss of function in these two opposing genes can paradoxically result in very similar phenotypes, a phenomenon that is still not fully understood.
Huh. Loss of opposing factors gives similar results. Weird.
It is puzzling.
And pituitary stalk interruption syndrome, or PSIS, is a distinct congenital defect.
Yes. PSIS is a congenital defect characterized by a thin or interrupted pituitary stalk, which is that crucial connection to the hypothalamus. It's also defined by anterior pituitary hypoplasia and underdeveloped anterior pituitary, and an ectopic posterior pituitary, meaning the posterior lobe is abnormally located.
Posterior pituitary in the wrong place.
Correct. This syndrome is often associated with other midline defects, eye abnormalities, and mutations in genes like HESX1, LHX4, OTX2, SOX3, PROKR2, GPR161, and ARNT2, indicating its complex genetic basis and developmental origins.
And finally, other syndromic disorders also have pituitary deficiencies as a component.
Indeed. Pituitary deficiencies have been reported in patients with a range of other syndromic disorders. These include CHARGE syndrome, linked to CHD7 mutations, syndromes associated with PX6 mutations, which is a key regulator of eye development, Kallman syndrome involving variants in genes like POKR2, FGF8, and FGFR1, and holoprosencephaly, linked to mutations in SHH, GLI2, and PGIF variants. This broad association underscores how intricately pituitary development is intertwined with broader neurological and developmental processes throughout the body.
So those are the complex genetic causes. But pituitary failure can also be acquired later in life. Our source emphasizes that this acquired form represents an underestimated burden.
That's a profoundly important clinical insight. While hypopituitarism is considered uncommon with an estimated prevalence of 46 cases per 100,000 people, its onset can be either acute and dramatic or insidious and slow. The manifestations, as we've discussed, depend entirely on which hormone axis is affected. It most commonly arises as a consequence of pituitary macroadenoma and the treatments used for them, such as surgery and radiotherapy.
Here's where it gets really interesting. Why is its prevalence so significantly underestimated in the general population?
It's underestimated precisely because many cases simply remain undiagnosed. This happens due to a critical lack of recognition of pituitary dysfunction as a common comorbidity of many major non-endocrine-related medical conditions or their treatment.
People just aren't looking for it.
Often, yes. If a clinician isn't specifically looking for it, or if the symptoms are vague, it's very easily overlooked, contributing to a significant hidden burden of disease.
And head trauma, particularly from contact sports, is an increasing but unappreciated cause. This is a sobering revelation.
It truly is. Traumatic brain injury, or TBI, resulting from motor vehicle collisions and increasingly from contact sports, is an expanding and often under-recognized cause of adult hypopituitarism.
Contact sports. Wow.
Yes. A meta-analysis of multiple studies showed that 15% of patients had a single pituitary deficit, and 4% had multiple deficits when assessed 3 to 12 months post-TBI. GH deficiency was the most prevalent at 13%, followed closely by ACTH deficiency at 12%, LH-FSH deficiency at 10%, and TSH deficiency at 4%.
GH and ACTH deficiency, quite high.
Worryingly so. This collectively equates to a significant incidence of 7 new cases per 100,000 persons per year, clearly posing a substantial public health burden that deserves more attention.
Those statistics are quite striking, especially regarding contact sports.
Indeed, high-impact sports like boxing, kickboxing, and American football carry a demonstrably high risk. For instance, studies have found GHD in 45% of retired boxers.
45%, yes.
In kickboxers, 22% had GHD and 9% had ACTH deficiency. A significant U.S. study specifically found GHD in 19% and hypogonadism in 9% of football players. The true and total burden of hypopituitarism resulting from impact sports is likely unrecognized and remains largely unknown, suggesting a silent epidemic among athletes.
Unrecognized burden. That's concerning.
It is. Data in children are sparse, but one study reported 7% GHD, 2% thyroid insufficiency, and 1% adrenal insufficiency 5 months post-TBI in pediatric patients.
Subarachnoid hemorrhage is another cause that is recognized but underappreciated.
That's accurate. Subarachnoid hemorrhage, which has an incidence of 6 to 10 cases per 100,000 people, peaking between ages 40 and 60, is a recognized but still underappreciated cause of pituitary dysfunction. A comprehensive meta-analysis of 20 studies found the prevalence of pituitary dysfunction to be approximately 46% in the acute phase following the hemorrhage, decreasing to 25% after 6 months, with GHD being the most prevalent deficiency.
Nearly half initially, wow.
Yeah, it's high. Interestingly, factors such as age, gender, pre-existing cardiovascular risk factors, or the radiologic grading of the hemorrhage do not seem to significantly influence the severity or incidence of pituitary dysfunction.
And how do these complex injuries make diagnosis so challenging for clinicians?
The diagnosis of pituitary dysfunction in the context of these complex injuries is made incredibly difficult by two main factors. First, the symptoms of hypopituitarism are often nonspecific and can easily be masked or misinterpreted.
Vague symptoms strike again.
Yes. Second, these symptoms overlap with the often profound and variable central nervous system consequences of the initial mixed brain injuries. This combination makes identifying pituitary dysfunction and managing it very challenging. In acute situations, the immediate focus is always on assessing the HPA axis, due to the absolutely vital role of glucocorticoids in the body's stress response and survival.
Got to check cortisol first.
Always. However, there's significant merit in deferring a full assessment of the other axes until the patient's vital systems are stable, as pituitary impairment from acute injury may sometimes recover over time.
Finally, radiation is a cause of hypopituitarism. How does the dose and time influence its progression?
The progression and degree of hypopituitarism due to radiation are profoundly dependent on the radiation dose, the time elapsed since exposure, and also the patient's age at the time of irradiation. The GH axis is definitively the most radiosensitive of all the pituitary axes.
GH gets hit hardest and fastest.
Correct. GHD can develop with radiation doses as low as 18G, and its incidence rises to 50% to 100% with higher doses, typically manifesting within 3 to 5 years post-irradiation. This is then followed, in terms of radiosensitivity, by the gonadotropin, ACTH, and TSH axis.
So the gonadotropin axis is affected after GH, but there's a surprising paradox regarding its response to radiation in children.
Yes, gonadotropin deficiency typically occurs with radiation doses exceeding 30G. However, here's the paradox. Lower doses of radiation in children can, surprisingly, cause central precocious puberty, where puberty starts too early.
Lower doses speed up puberty. That's weird.
It is counterintuitive. Additionally, pituitary irradiation can also induce hyperprolactinemia, which is likely due to damage to the hypothalamic dopamine pathways. This typically develops with exposure to 40J or higher and can affect both sexes across all age groups.
So, given all these potential causes, both genetic and acquired, how crucial is screening for pituitary insufficiency, and who should be screened?
It's critically important because, as we've discussed, hypopituitarism can develop insidiously and may not be clinically apparent to the patient or even to their physician until it's quite advanced. Therefore, proactive screening is absolutely crucial to prevent significant and preventable long-term morbidity and improve patient outcomes.
Who specifically should be screened?
Well, the list is comprehensive. Patients with hypothalamic or pituitary mass lesions, any developmental craniofacial abnormalities, inflammatory disorders, brain granulomatous disease, prior head or neck irradiation, history of head trauma, prior skull-base surgery, those with a newly discovered empty sella on imaging, and individuals who have experienced pregnancy-associated hemorrhage or significant blood pressure changes, such as in Sheehan syndrome.
Broad criteria.
Yes. When initially assessing these patients, prolactin should always be measured first because secondary hyperprolactinemia is a common finding, especially with pituitary macrodenomas and other paracellular lesions. In fact, up to 2/3 of patients with pituitary macrodenomas, craniopharyngiomas, and other paracellular lesions have compromised pituitary reserve function.
And what about ongoing monitoring after treatment?
Ongoing monitoring is vital. Approximately 1/3 of patients undergoing pituitary surgery actually recover some function after decompression of the gland, which is a positive outcome.
Good news for some.
Yes. However, conversely, about 25% of patients experience further loss of pituitary function post-surgery over time. Therefore, to catch new or worsening deficiencies, patients should be meticulously screened annually for their pituitary function. The treatment regimens generally involve targeted replacement therapies for each specific deficient hormone, as we've meticulously detailed, including somatotropin for GH, desmopressin for vasopressin deficiency, thyroxine for TSH deficiency, hydrocortisone for ACTH deficiency, and estrogen or testosterone for gonadotropin deficiency.
So what does this all mean when we bring it together? We've journeyed from the historical misnomers of the pituitary to its incredible, finely tuned orchestration of virtually every major body system. This tiny gland, weighing only about 600 milligrams, is truly a master of balance, regulating growth, reproduction, stress response, and metabolism with astonishing precision.
Understanding the pituitary gland isn't just about memorizing the names of hormones or their functions. It's about appreciating the profound complexity of the multi-tiered systems that meticulously keep us functioning, adapting, and thriving every single day. It's truly a shortcut to being profoundly well-informed, almost like an elite professional, about the very core of our physiological being and the intricate symphony that defines human health.
Considering its central role and incredibly delicate balance, the pituitary often presents its dysfunction with subtle, widespread symptoms that can mimic a multitude of other conditions or even be dismissed as simply just getting older.
Mm-hmm.
This raises an important question for all of us as a society and as individuals. How might we become better equipped to recognize these silent signals of pituitary imbalance earlier in our lives and proactively address the underlying endocrine issues rather than simply dismissing them as the inevitable march of time? It's not just about more precise diagnostics. It's about cultivating a deeper societal awareness and appreciation for the body's internal symphony and knowing when to listen more closely for notes that are out of tune.